Bismillah, live chat is there. Good evening, G. Good evening, G. Good evening, all. I hope I'm audible and the screen is visible. So these days, actually, I start the session with the blessings of the Lord. So blessings of Shri Guru Nanak Dev Ji with us. Fine. I'll start the session. Right. Thank you so much. May the Supreme be with us always, always, always. May the Supreme be with us always. Okay. Dr. Vinay Reddy Ji, I'll definitely share the PDF. PDF will share. I'll definitely share the PDF. Fine. You don't need to worry about it. I'll definitely share the PDF. Okay. Right. So the plan of the lecture will be like this, that we'll read the topics, we'll read the important topics. Basically, only some which are a topic which are not so important will not cover that. Otherwise, we'll cover every single topic. Fine. Then in between, we will see some important images. We'll see some important images. Fine. Now, we'll wait for 1 or 2 minutes and then we'll start the session. Right. Okay. Right. So first thing, we have to start with the deformities, right? Your patient can have congenital deformities. Your patient can have acquired deformities. For example, the important congenital deformities, let's say your patient has got club foot. Remember, club foot is also called as CTEV, congenital talus equinovarus. So you need to understand the meaning of these words. For example, we all have seen this word congenital, that means since birth, talus, equinovarus. So we need to understand the meaning of this word. I believe you have already read it. You will be well versed with the things, but let's quickly revise them. Let us quickly revise them. Okay. Now, if there is any deformity at the elbow, the prefix means the first name of deformity, that will be called cubitus. If there is any deformity at the hip, the name will be coxa. Deformity at the knee, name will be genu. Deformity at the hand or wrist, name will be manus. Deformity at the toes, name will be hallux. Fine. Deformity at the foot, either we call it pes, or if there is deformity involving the ankle joint, we call it talus also. We call it talus also, right? Now, all eyes on the screen where the camera is there, right? Now, let's see. So anything and everything which you see on your screen now, that is my anterior aspect of my body, right? Anterior aspect of my body. Suppose I am your patient. Now, this what you see on the screen, that is the anterior aspect, anterior. If this is anterior, right? This is posterior. Anterior, posterior, right? We'll first revise the basic motions. Now see, look at my hand, my arm. So this is the anterior aspect. Anterior aspect is also called as ventral aspect, is also called as volar aspect, is also called as flexor aspect. Fine, flexor aspect. Now the surface of the hand, this is called palmar aspect, right? So once again, see here, anterior, posterior, ventral, dorsal, flexor, extensor. Very quick revision. Anterior, posterior, ventral, dorsal, flexor, extensor. Now, the ventral surface is also called as volar surface, right? Now, see, look at my hands. If I do like this, right? Now, look at my right hand. If I do like this, that is called as flexion. Now, look at my hand. So, if I do like this, that is simply called as flexion or palmar flexion. And if I do like this, that is called as extension or dorsiflexion. Okay, G? Flexion, also called as palmar flexion. Extension, this is called as dorsiflexion. So I have done dorsiflexion of both my hand. Dorsiflexion of both my hand. Keshavji, the tea party is there, but tea is black in color, and it has got some pungent flavor. You got the point. Okay. So you see like this. Okay. So all the surfaces, I'll revise twice or thrice at least. Now, so the name, for example, let's have a look at this deformity. The name is Talipes equinovarus. We shall see all these deformities. Now, whether our patient has valgus or varum deformity, what do we do? To check whether our patient has valgum or varus deformity, we look at, what do? We look at distal most part. We look at distal most part of the limb. Distal most part of the limb. Mihirji, 11:30. 11:30 is tentative. We can, yeah. Dr. Vinay Reddy has already mentioned. We look at distal most part of the limb. Now see here. In the first image, interchange, right? Now see here. So in the first image, the distal most part, that is the feet, they are going inwards. Feet, they are going inward. So if the distal most part is going inward, that is called as varum deformity. If the distal most part is going outward, that is called as valgum deformity. Okay. Now see, this one is absolutely normal pelvis. Hip joint is normal. Knee joint is normal. Now what we do to check whether the hip joint is normal or not, step by step, very quickly. First, we take the X-ray of the hip. Second, we draw a line. Through the neck. Of femur. So let's draw a line through the neck of femur. Let's call this A. Second, we draw a line through shaft of femur, like this. And then we measure the angle between the two. Now this angle is called neck shaft angle. It is between 110 to 135 degrees. If this angle is between 110 to 135 degrees, we say that everything is normal. Okay. Now, let's say here hip joint is normal because the angle between neck shaft angle is between 110 to 135 degrees. Fine. Now, hip is normal. Even then, the feet are going outward. That means there is some problem at the knee joint. So knee joint is abnormal. Because the knee joint is abnormal, we get the name genu. Because the feet are going outward, we get the name valgum. So your patient has got genu valgum. Let me show you the picture of genu valgum. See here. Look at this image. the feet are going outward, your patient has got genu valgum. Genu valgum. See, the feet are going outward. Feet are going outward. That means your patient has genu valgum. Okay. Now, genu valgum is also known as knock knee, is also known as knock knee. Again, the hip joint is normal. That means the neck shaft angle is between 110 to 135 degree. 110 to 135 degree. But you see, knee joint is abnormal and the feet on the both side, they are going inwards. Feet on the both side, they are going inwards. Because the knee joint is abnormal. So name of the deformity is genu. Because the feet are going inward, name of the deformity is varum. Now this deformity is also called as bow leg deformity, right? Now here, hip joint is abnormal. Hip joint is abnormal because when we took the X-ray, we saw that the neck shaft angle is more than 135 degree, is more than 135 degree. The feet are going outward. Feet are going outward. Because the hip is abnormal, name is coxa. Because the feet are going outwards, the name is valgus. So your patient has got coxa valgus. No specific name. No specific name. Right? Now here, hip joint is abnormal. And here, what did we notice? That the angle between neck of the femur and shaft, neck shaft angle is less than 110 degree. The feet are going inward. Because the hip is abnormal, the name is coxa. Because the feet are going inward, the name is varum. So your patient has got coxa varum deformity. Coxa varum deformity, right? Okay. Now, the same deformity in the hands. So very, very quickly. Now, let's say what we do. So this patient is absolutely normal. Again, we'll take an X-ray. We draw a line through the mid of arm. Then we stretch it on the other side. Fine. Then the second line, we draw through the mid of forearm. We draw through the mid of forearm. And then we see the angle between these two lines, angle between these two lines. Now this angle in males is between 5 to 10 degree, and females, because they have wider pelvis, it is between 10 to 15 degree. Hello, Satish Reddy ji. Glad to have you here. Fine. Now see, in the first image, that is image A, so it is going towards midline. So the angle between these two lines is less than 5 degree, is less than 5 degree. Because the problem is at elbow, we say our patient has got cubitus varus. Now look at this image. Here, this angle is more than 15 degree and the hand is going outwards. So our patient has got cubitus valgus deformity. Cubitus valgus deformity, right? In between, I'll keep on asking some questions also, right? Now, if the problem is at wrist joint, fine. Problem is at wrist joint, so we get the name manus. And because the fingers are going inwards, we get the second name varus. So our patient has got manus varus, manus varus. Now, this is typically seen in the congenital disorder club hand, congenital disorder club hand, manus varus. Similarly, for the feet, you see here, if the feet are going inwards, fine, that means our patient has got talus varus. If they are going outward, that means our patient has got talus valgus. Okay. Now, if the heel is not touching the ground, that is called as equinus, talus equinus. If the forefoot is not touching the ground, that is called as talus calcaneus, talus calcaneus, right? Okay. Now, if the great toe is going outward, problem at the great toe, the name is hallux. And if it is going outwards, the name is valgus. Okay, hallux valgus. Now look at this image. Image number 1, great toe is going out. Image number 2, the great toe is going inwards, right? This is the midline, right? So this patient has two deformities. If our patient has valgus deformity in the one limb and varus in the other, this one is called as wind sweep deformity. This is called as wind sweep deformity. Okay. Right. Now, let us see some of the question. Can you guys check what is the X-ray showing on your screen? What kind of fracture is the X-ray showing on your screen? In between, we'll keep on shuffling. I'll keep on asking you some questions and you'll keep on telling me the answer. Thank you, Dr. Medical Student G. But you have to tell me the name. Okay, I'll answer it. I'll write the options over here. Fine. Whether it is Gallese fracture, whether it is Monteggia fracture, fine. Whether it is Barton fracture or nightstick fracture. What fracture it is? What fracture it is? Please tell me. Now, see, dear doctor, this bone is radius and this is perfectly fine. Remember, there is a very good mnemonic, GFR. Gallese fractures the radius. Gallese fractures the radius. Perfect, Dr. Pradipta Roy ji. Ulna is fractured. There is no dislocation anywhere. So your patient has got nightstick fracture here. So it is said to be isolated fracture. It is said to be isolated fracture of ulna. The word isolated means there is no other fracture or no other dislocation, no other fracture or no other dislocation. Isolated fracture of ulna. Now this is also called as defense fracture. This is also called as defense fracture, right? That's one thing. Okay. Tell me, what is this fracture, what you see on your screen? What is this fracture, what you see on your screen? I have been using this trick for the last 4-5 years. And every time some of the students, they get trapped in this trick. Anyone? Dr. Medical Student Ji, Dr. Mihir Ji, Dr. Vinay, Dr. Shweshka, Dr. Stuti, Dr. Shravanti Ji. I hope I'm pronouncing your names correctly. And I also hope you guys don't mind me calling by your names. Anyone? Like, kya baat? Medical Student Ji, अपना नाम बताइए पहले. You gave the right answer in the first go, but then you changed it. You see, dear doctor, there is no dislocation. Both the bones are together. This one again is nightstick fracture only. This again is nightstick fracture only, right? There is no dislocation. Barton fracture would be like this. Barton fracture is an intra-articular fracture and displaced fracture, right? Now, again, tell me, what is this fracture? What is this fracture, what you see on the screen? Okay, right. So you have not read the orthopedics as of now, I believe. So you are doing full justification of your name, medical student. Okay, what fracture do you see on your screen? Thank you, Dr. Stuti. This time you give the right answer. So this again is nightstick fracture. This again is nightstick fracture. Again, I don't want to play games with you. This one again is nightstick fracture. This again is nightstick fracture because these fractures, they very often bother us. So let's quickly check these different fractures, right? Quickly, we will check these three fractures. Okay, so as you can see, nightstick fracture is an isolated fracture of ulna. It is also called as defense fracture. It is also called as defense fracture. Okay, then we have to see these things. Monteggia fracture dislocation, right? Now see here. First, you remember this mnemonic. It is already written. That is the very first, very most important mnemonic for you to remember. If you remember this mnemonic, then rest of the lines are clear. So GFR, glomerular filtration rate, will use this as a mnemonic. Gliese fractures the radius. If you don't like this mnemonic, fine. Another mnemonic, Mugger, fine. Monteggia will fracture the ulna and Gliese will fracture the radius. Gliese will fracture the radius. That's one mnemonic. Now, when you are writing the word Gliese, Z is the prominent word. Now, if you start reading ABC, Z comes at the end. So that means Gliese will fracture the bone where it ends. That means it will fracture the distal radius. It will fracture the distal radius. Now, when you write the word Monteggia, you see ABC, it starts with A. So Monteggia will affect the bone where it starts. Fine. Monteggia will affect the bone where it starts. That means Monteggia will fracture the proximal ulna. Monteggia will fracture the proximal ulna. Right? Now, I did develop my own mnemonic long time back. Right? Now, when did I develop this mnemonic? I developed this mnemonic in the year 2019, 2019. Fine. At that time, we are not talking about politics. We are just using this as an example. We are just using this as an example. Okay. Now, what happened in the year 2019? There were general election and M for Modi ji. Fine. So he won and became prime minister. Why did he won? Because he was close to the hearts of people. He was close to the hearts of people. See here. Now, if I'm standing here, my heart must be somewhere here. Right? Now, which part of the body, heart is close to which bone? This bone is ulna. So, heart is closer to ulna. So, M, Modi ji in the hearts of people. Monteggia will fracture ulna. Which part of ulna? Whatever is close to the heart. Okay. So, M for Monteggia. Monteggia will fracture the proximal ulna. Now, all his life, Modi ji did politics against one political family, that is Gandhis. So G stands for Gliese. Totally opposite. So Monteggia fractures the proximal ulna. Gliese will fracture distal radius. Will fracture distal radius. Right? Now, what happened? That somebody suggested one of the Gandhis that you too can become prime minister. Dr. Stuti, yes, that's a perfect mnemonic. M for Mundi. Mundi means the head. So that means Monteggia will start at the top. And G for ground. Ground, okay? Now, ground is at the base. So Gliese will affect the distal part. That's a good mnemonic. Thank you, Dr. Stuti. Now, see. So somebody suggested one of the Gandhis Which Gandhi? RG, Rahul Gandhi, that you too can become Prime Minister, just stand in the line, right? So reverse Galeazzi will affect the distal ulna, right? So that is one way of remembering. Now let's quickly see. So this is Monteggia fracture dislocation on your screen. Again, proximal ulna fracture with dislocation of radio-ulnar joint. Now, on your screen, you can clearly see here that radius is perfectly okay. You can see that the radius is perfectly okay. It is the ulna which has got a fracture. And then you see closely over here, I'll zoom in. Now see, the radius and ulna are not together anymore. They are separated from each other. So what you see over here is dislocation, right? Dislocation. So Monteggia fracture dislocation, two things. First, there will be proximal ulnar fracture and then proximal radio-ulnar joint dislocation. Okay. Then let's see Galeazzi fracture. Now, as you can see over here in the Galeazzi fracture, ulna is perfectly normal. It is the radius which is fractured. And then you can see there is massive dislocation between the radius and ulna. So Galeazzi fracture, first distal radius fracture, that's one thing. And second is dislocation of radio-ulnar joint. Now there is another fracture. This fracture is called Galeazzi equivalent fracture. So here ulna will be fractured, radius will be fractured, but there will be no dislocation. Both of them will break, but they will not get separated from each other. So there is absolutely no dislocation. This one is called Galeazzi equivalent fracture. Important, please. Okay. Now, you see, any bone, the outer part of the bone is cortical. Outer part of the bone is very hard. Outer part of the bone is very dense. Once you see on the blue color, let me zoom up and then I'll zoom out. See here. So the outer part of any bone is cortical, whereas inner part of the bone is cancellous. Okay. Now this is the point where Galeazzi fracture generally occurs. Now, if the fracture occurs further distal, I'm showing you the radius bone with my bad drawing. Now see. So where there is junction of cortical bone and cancellous bone, if fracture occurs there, that will be called as Colles fracture. Now, cancellous bone. Cancellous bone is the inner part of every bone. Now, it is hard, of course, it is also hard, but it is less dense. It heals extremely rapidly. It will heal extremely rapidly. Okay. Now, Colles fracture. What is the mechanism? Mechanism of Colles fracture is foosh, fall, over, out, stretched hands. Now this occurs in elderly. You see, buddies, foosh. If it occurs in children, it will cause fracture of humerus. So SCF is supracondylar fracture of humerus. Now, if it occurs in young adults, it will cause scaphoid fracture. And if it occurs in elderly, it will cause Colles fracture. Now that's super important. Very good. Dr. Vinay Reddy ji, will you please answer my question? What is the most common complication of Colles fracture? What is the most common complication of Colles fracture, Dr. Vinay Reddy ji? Now, very quickly. Meanwhile, Dr. Vinay Reddy answers. Let's see. Now, my hand is supine. If I do like this motion is pronation. If I do like this motion is supination. Okay. Yes. Dr. Medical student has given the right answer. So, buddy, see, the problem is when we talk about Colles fracture, we are only thinking about one thing, dinner fork deformity. But Colles fracture, when we were in the college, at that time, if we were talking about dinner fork deformity, it was okay. But now the things have gone beyond that, too much beyond, right? Now, see, so my hand is like this. If I do it like this motion is pronation. If I do it like this motion is supination, right? Now, look at my fingers. Which finger is close to my body? The little finger. Okay. Now, okay, which bone is close to my body? Ulna. Which bone is far from my body? Radius. I'll come here. You see. Now you can see? No, it's not good. I'll stand here only. Okay, you see, ulna is closer to my body. Now, please tell me very quickly. If I do like this, if I do twist my finger like this, whether it is medial rotation or lateral rotation, my kind request, just answer only for 2-3 minutes. After this, I will not ask you to answer for 15-20 minutes. But for now, please type something, whatever I'm asking. If I do like this, whether this is medial rotation or lateral rotation, medial deviation, not rotation, deviation. Okay. Now you see, when I'm doing medial deviation, my fingers, they are moving towards ulna. So if I do like this is medial deviation, also called as ulnar deviation, right? Now, if I do like this, this is called as radial deviation. This is also called as lateral deviation. Fine. Lateral deviation or radial deviation. Right. Once again, if I do like this, that is dorsiflexion. Fine. If I do like this, that is palmar flexion. This part, anterior ventral volar. I told you I'll be doing this twice or thrice. Okay. Anterior ventral volar flexor. Dorsal posterior extensor. Right? Okay. So if I do like this, that is flexion, also called as dorsiflexion. If I do like this, fine. If I do like this, that is, sorry, I missed something. Now correct. If I do like this, that is called as dorsiflexion. Dorsiflexion. Right? If I do like this, that is called as palmar flexion. But dorsiflexion like this is also called extension of the wrist. Right? Do remember. See, flexion, extension, flexion, extension. Okay. Now, quickly, we'll see. So, Colles fracture, when the patient comes to you, what happens is You see, Colles fracture is affecting the radius. When the patient comes to you, what happens? The radius bone is broken into two parts, 1 and 2. Now, this happens to be the distal fragment. This happens to be the distal fragment. Now, you see what has happened here. That distal fragment has gone posteriorly, But if there would have been no fracture, the distal fragment would have been lying here. But now it is broken, so it has gone posteriorly. So if they ask you about the Colles fracture, the clinical feature will be slip. Your patient will present to you in supination. When you look at the fingers, you will notice that there is lateral angulation of fingers. You see that the both bone fragments are stuck up. So what is impacted fracture? Impacted fracture is both fragments are stuck up. Both fragments are stuck up. If your examiner asks you a difficult question, he will ask you about bony fracture. What is special about bony fracture? So in impacted fracture, bony crepitus is absent. In impacted fracture, bony crepitus is absent. What is bony crepitus? It is seen when the bone fragments rub against each other. Bone is broken into two fragments. When they rub against each other, like this, that is called as bony crepitus. Yes, Dr. Doom? बड़ा खतरनाक नाम रखा हुआ यार, डॉक्टर धूम ही रख लेते. Just add an H. Okay. And then there is posterior shift of distal fragment. Posterior shift of distal fragment. Okay. Now, what is the treatment? From supination, treatment mnemonic is propaganda. From supination, we will convert it to pronation. Patient came like this, you'll do like this. Patient came in supination, you will do pronation. Okay. Patient came in dorsal angulation like this. Patient came in dorsal angulation. Like patient came like this. You'll convert it like this. That is palmar angulation. When patient came, the fingers were like this. Now what you will do? You will do it like this. You'll do it like this. Patient came like this. You'll do it like this. So from lateral deviation, you will convert it to medial deviation, which is also called as ulnar deviation. Propaganda is the mnemonic. And this all can be done in the handshake cast. Now, what do you see in the handshake cast? I've got a bad handwriting. So handshake cast, what you notice is that the fingers, they go towards ulna. Right? And then you see here, the hand is having palmar deviation. Now, how do you identify handshake cast? So in handshake cast, the thumb is free. It is not under the cast. Okay. Now, once again, what is the deformity? Deformity is dinner fork deformity. See, buddies, here, this is normal bone. First image. Second image, there is a fracture. Those of you who are finally a student, most of the teacher, rather than writing the full word fracture, will be using the hash symbol. Hash symbol means fracture. Right? Okay. Now, what had happened at the time of fracture? The distal fragment had gone posteriorly. posteriorly. And if you don't do the treatment properly, it will unite there only. It will unite there only. So this is distal fragment. We know that it had gone posteriorly. This is the posterior aspect. If you don't do proper treatment, it will unite here only. It will unite here only. Right? Now, this kind of deformity is called dinner fork deformity. Dinner fork deformity. So D for dinner fork deformity. It is extremely disabling deformity. Fine. It will make the working of your patient like hell. He will be uncomfortable in anything and everything. Eating the food, uncomfortable. Opening the key, uncomfortable. Fine. Washing the face, uncomfortable. Every activity will be uncomfortable. Okay. Then we have to do corrective surgery. So name of corrective surgery is Darach operation. Now, this question has come in examination many a time. Most common complication is finger stiffness. Other complication, compartment syndrome, Sudak dystrophy, myositis ossificans. Now, if you're appearing for NEET PG, please do remember that rupture of extensor pollicis longus is a late complication. It is a late complication. Okay. Now see, here what has happened, the bone got broken into two parts, distal and proximal. This is distal, this is proximal. Distal part had gone posteriorly and the fracture united here only, which gave rise to dinner fork deformity. Dinner fork deformity. Okay. Now, Smith fracture is totally, absolutely reverse of Colles fracture. Absolutely reverse of the Colles fracture. It will occur due to fall on the inward turned hands. The clinical feature, patient will come to you like this. So clinical feature will be pronation. Clinical feature will be palmar angulation. You see palmar angulation, right? Clinical feature will be ulnar deviation of the fingers, ulnar deviation of the fingers. Treatment is slip. From pronation, you will convert to supination. Fine. From ulnar deviation, you will convert to lateral deviation and you will make the patient immobile. You'll make the fracture immobile in a cast. Then posterior shift. Let me tell you what is posterior shift. See here. So let's say the fracture, distal fragment, proximal fragment. If the distal fragment goes posteriorly, this becomes a Colles fracture. If the distal fragment goes in the opposite direction, this becomes a Smith fracture. Smith fracture. Now, if it unites like this will give rise to typical garden spade deformity. Typical garden spade deformity, right? This garden spade deformity. It will be like this, here, here, and here. Garden spade deformity. Colles was exactly opposite. Okay. Now, the next thing here, only 1 or 2 minutes, but before we start, let's answer 2-3 questions, right? I mean, you will answer these questions. So you see, I want to see whether you're able to see this or not. Very quickly, all what we have read till now, please tell me what is this fracture. If you want me to zoom anywhere, if you want me to zoom at any of these points, please tell me. If you want me to zoom at any of these points, please do tell me. I'll do it for you. You guys won't say. What is this fracture? Tell me. Your drug of choice, Sahab? Nahi. Look at this fracture. There's no room for mistake. There is no room for mistake. Dear buddies, see, the radius and ulna are separated from each other. Radius and ulna, they are separated from each other. There is no room for mistake. Dr. Stuti gave the right answer. Dear doctors, ऐसे मत करो please. Exam बहुत पास है. There is ulna fracture. There is dislocation of radio-ulnar joint. Dislocation of the radio-ulnar joint. So it is a Monteggia fracture. Never make the mistake. So you see there will be dislocation at the radio-ulnar joint. There will be fracture of ulna. Fine, fracture of ulna. So this is a Monteggia fracture. Now name this fracture. Name this fracture. Don't make any mistake this time, please. Now, many of you are confused that we are not able to identify radius or ulna. See, buddies, this side is distal, this side is proximal. So, radius is like this, broad distally and narrow proximally. And ulna is opposite. Ulna is like this. Ulna is like this. So ulna is narrow distally and broad proximally. You are able to identify. अरे भाई नाइट स्टिक क्यों बोल रहे हो यार? अल्ना इज परफेक्टली ओके. क्या करते हो डॉक्टर साहब यार? नाउ सी, गैलीजी. It is a Galeazzi fracture because the radius is broken. Radius is broken. Let me zoom up for you guys. See, the radius is broken here. Radius is broken. And there is dislocation of the radio-ulnar joint. Yes. See here. The radius will be broken and there will be dislocation of the radio-ulnar joint. Dislocation of the radio-ulnar joint. See, buddies, ulna is perfectly okay. It is the radius which has a fracture and then there is a dislocation. क्या फायदा हमारे इतने mnemonics पढ़ने का? Now tell me, what is this fracture? What is this fracture? No room for mistake. Absolutely no room for mistake. See, buddies, look at the distal part of ulna. Look at the cursor of my mouse. There is fracture in ulna. There is fracture in radius. There is fracture in ulna. There is fracture in radius. Fine. Okay, and there is a dislocation. So if you see both, first fracture you see fracture of ulna, fracture of radius. You don't see any dislocation. So you will call it Galeazzi equivalent fracture. But if you look at the other second one, you see there is mild dislocation. So we'll call it Galeazzi fracture. Galeazzi equivalent you have already seen. Now, this part of the radius is called styloid process. Now, if there is fracture of styloid process, that is called as Schoffer fracture, also called as backfire fracture. So if you see, this is the Schoffer fracture. Schoffer fracture, also called as backfire fracture, also called as backfire fracture. Fine, tell me, what is this fracture now? You see here the radial styloid process is broken. Radial styloid process is broken. Now let's very quickly do one or two clinical questions. Then I'll show you some x-rays. I hope you will be able to answer these. So here they have asked you that the following type of pelvis is seen in which condition? The following type of finding, the following typical finding is seen in which condition? Anyone, please? Typical finding. That's an extremely typical finding. Wow. So what do you get to see? You get to see champagne glass pelvis. You got to see champagne glass pelvis. You see, this kind of pelvis will be very, very wide, but it will not be tall. It will not be tall. Champagne glass pelvis seen in achondroplasia. The following condition can be seen in. The following condition can be seen in. Now, this is showing you synostosis. Synostosis means the fusion of bones, fusion of two bones, synostosis here. So synostosis is seen in all of the conditions. Synostosis means the fusion of the bones. It is seen in all the conditions. Holter-arm syndrome, Klinefelter syndrome, even after trauma, even after trauma. Okay. Now, answer this question, please. After that, we'll shift to one or two topics here. Don't worry. Answer this question, please. So 68-year-old male presents with severe knee pain and swelling in the knee joint. X-rays were taken which returned the following picture. X-rays were taken which returned the following picture. Anyone please answer here? 1, 2, 3, 4. Now you see, I'll answer that for you. Now here you see that the cortex is broken. Cortex is broken, right? So these kind of findings, they're typically seen in neoplastic secondaries. You won't believe, buddies, I'll not reveal much details about the patient, but yesterday in the OPD, one of my patient came to me. Now we did perform modified radical mastectomy on her. Fine. We did perform modified radical mastectomy on her, and that lady had severe pain in the knee. And you know what the non-medical people do? So what she did was she read about some of the lines. She read about some of the lines on Google, and she asked me that, doctor, could this be the breast cancer moving to the bones? Fine. My reply was instant, no, it is not. Now, please tell me why I was so confident. Because you see, most common bone tumor are secondary cancer from other organ. They are secondary cancer from other organs, right? Now, it is, in males, they come from prostate, and overall also they come from prostate, male and female combined. So cancer will come from prostate, cancer will come from breast. Now, some of the cancers, they increase bone formation. They are called as osteoblastic. What is the mnemonic? PCM, cancer of prostate, carcinoid, and medullary carcinoma of thyroid. While some of the cancers are osteolytic. So what do? They destroy the bone. Now, these cancers are renal cell carcinoma. These cancers are follicular carcinoma of thyroid, follicular carcinoma of thyroid, right? Now, in breast cancer, 80% tumors are lytic and 20% patients have blastic secondary. Now, what happened there? Yes, Dr. Meherji, your drug of choice. See, what happens is that lady read that breast cancer can go to bone, and she read it correctly. In females, the most common cancer going to the bones is breast cancer only. But what she did not read on the Google was this line: cancers are rapidly growing tissue, so they prefer to remain near the source of blood supply. That is why the most common site is dorsolumbar spine. And where? On the posterior aspect, on the posterior aspect. But There is a mnemonic, BBC, British Broadcasting Corporation. It says their reporters go everywhere, around the world, their reporters go. So BBC goes everywhere. So carcinoma bronchus, carcinoma bladder, carcinoma colon, they can go to any bone. They can go to any bone, even smaller bones. For example, they may be seen around knee joint, they may be seen around ankle joint, they may be seen around elbow joint, but not the breast cancer. Breast cancer will be seen in dorsolumbar spine or maximum at hip, not beyond this. Okay. Now, if they ask you what is the most common primary malignant bone tumor, primary means arising from the bone itself, arising from the bone itself. Okay. Now, most common primary malignant bone tumor is multiple myeloma. Multiple myeloma arising from red bone marrow. Most common primary malignant bone tumor of non-hematopoietic. That means originating from the hard bone. Now, this one happens to be osteosarcoma. Osteosarcoma. Second most common, chondrosarcoma. Third most common, Ewing sarcoma. Right? Now, osteochondroma. We'll quickly revise the tumors in 5 to 10 minutes, and then I'll ask you questions on tumors also. Right? Now, see, osteochondroma, that's the most common benign bone tumor. It is not a true tumor because growth of this tumor will stop at skeletal maturity. Let's say this is the bone of child and this is the tumor. The child will grow on to become an adult and will have big bones. But the tumor will remain small only. Tumor will remain small only. Now, this is important for INECET, right? Now, it is associated with Masada syndrome, important for Neet PG, right? Now, treatment is excision only if it is symptomatic. Then, enchondroma. It is the most common benign tumor affecting the hand bones. Most common benign tumor affecting the hand bones. And which hand bones? Phalanges. Phalanges. Fine. Now, it is associated with two syndromes. Their names are very, very important. Enchondroma is associated with Ollier disease and Maffucci syndrome. Ollier disease and Maffucci syndrome. So the tumor will appear like this. Please tell me, how do I need to adjust my speed? If you want me to adjust the speed of my lecture, please don't hesitate to inform me. Right? I wish to deliver as much as possible, so I'm trying that. But if you want me to adjust, do tell me. Now, osteoid osteoma, that's a very, very important tumor. Now, after this, I'll ask question on tumor. And if you give wrong answer, that will be very bad, please. Fine, don't give wrong answer after reading. Osteoid osteoma, that's the most common benign true bone tumor. Okay. Now, most common age. Robbins' textbook of pathology, it says it is common in teenage and early 20s. So, most common age is 10 to 20 years. Okay. Now, this X-ray image is the only thing which you need to know, and one clinical feature. So you see, outer part of the tumor will be white, inner part will be black. Inner part will be black. Very good, Dr. Sarvanti. I hope I pronounce your name correctly. But that was a second important thing here. Extremely important, right? So it has got typical clinical feature that the pain relief occurs with aspirin. Why? Because it is a benign tumor, so that is why your patient will have mild pain. Okay. Now, osteoblastoma, you can simply call it immature version. You can simply call it immature version of osteoid osteoma. Immature version of osteoid, osteoma. See, on this side, I will write osteoid, osteoma. Fine. And here I will write osteoblastoma. Let's quickly compare. Fine. Let's quickly compare. So you see osteoid osteoma less than 2 centimeter. This one is more than 2 centimeter. This pain relief with aspirin. Pain relief with aspirin. And here no pain relief. So this is said to be an aggressive tumor, said to be an aggressive tumor. So that is why the treatment is marginal excision, marginal excision. That means along with the tumor, we remove some normal healthy tissue also. Another 5 minutes of tumors and then I'll ask some questions. Now, osteoclastoma. Now, there are several E's about osteoclastoma. Fine. So you see here, E is epiphyseal. So let's say this is diaphysis, the middle part of the bone. This is metaphysis. And this one is epiphysis. So tumor will be present at the epiphysis. Tumor will be present at the epiphysis. But it will not be present in the center. It will be present at one of the sides of the bone. One of the sides of the bone. Tumor is expansile, increasing in size rapidly. Now it makes the bone very thin. It makes the bone very thin. And en bloc excision is the treatment. That means we will have to remove healthy bone also. Now, X-ray is typical. See, it will show soap bubble sign. Now you see the bone has become very thin. So if you press it, it will give you eggshell crackling sound. Eggshell crackling sound. You see by yourself, it is located at epiphysis. This is metaphysis. This is diaphysis, right? It is called as giant cell tumor because biopsy will show multiple giant cells with 40-50 nucleus, 40-50 nucleus. Simple bone cyst. This is important. It is located here at the upper end of humerus, right? Upper end of humerus. And which part? It is located at metaphysis. Okay. Now, other thing which is important here is this. So you will get to see this is called as trap door sign. Trap door sign, also called as fallen leaf sign, also called as fallen leaf sign. So if you see here, you get to see in this circle that there is a bone fragment. There is a bone fragment. So this image is very important. There is a bone fragment, right? Now, aneurysmal bone cyst. Aneurysmal bone cyst. This point is important for Neet PG. That what is the problem? Sorry, this point. That what is the problem? USP6 gene mutation. So there is upregulation of this enzyme which destroys the bone, Now, X-ray will show multiple septa, but the most important thing, it is seen at metaphysis. It is seen at metaphysis. Often, the students, they confuse it with Ewing sarcoma, but Ewing's will be seen at diaphysis. Ewing's is seen at diaphysis, right? Now, another thing, When you look at the X-ray closely, you will see fine lines. You will see fine lines. Now, they are septate. They are septate, right? Important. You see in this image also, you can see fine lines. Septate. They're called as septate. Now, this is typically called as finger in the glove. Finger in the glove. Finger in the glove sign on X-ray. Finger in the glove sign on X-ray. Okay. Right. Now we move to the next thing, osteosarcoma. Three benign malignant tumors. It is the most common malignant bone tumor of non-hematopoietic origin. Make no mistake, most common malignant tumor, most common primary malignant tumor will be multiple myeloma, right? It is the most common radiation-induced bone tumor. Now, when the tumor is caused by radiation, most common site is skull. This point is important for NEET PG. Yes, it may go on expanding. It may go on expanding, but it will start at metaphysis only. Now, so if they ask you, what is the most common site? You must remember this. Most common site is metaphysis of distal femur. It is common in males. Fine. Two type. Primary osteosarcoma, it will arise from healthy bones. Now, this kind of cancer is common in young. Fine. And this type of cancer is much more common. Secondary osteosarcoma. This occurs in diseased bone. Fine. Now, Paget disease and fibrous dysplasia, they're commonly associated. Common gene mutation associated, just remember these two, TP53 and P53, right? These are important for NEET PG, but this is even more important, RB, gene mutation. Now, what do you get to see on X-ray? Now, we see this kind of image like this. Now, this is the lifted up periosteum. Lifted up periosteum. Here, there is tumor. Remember, bone is attached to the periosteum with the help of Sharpie fibers. So, what will happen? The bone will start growing. Bone will start growing over the Sharpie fibers. Bone will start growing over the Sharpie fiber. Now, this is called as sunburst appearance, also called as spiculated appearance, also called as spiculated appearance. See here. So, wherever you see fine fibers, like this, fine means thin. Wherever you see the fine fibers, right? You say that it is a typical sunburst appearance, right? Now, sometimes what may happen is that periosteum may just be lifted. Now, this is typically called as Codman triangle. Typically called as Codman triangle. Codman triangle. Okay. Codman triangle. Okay. Now, biopsy will show nucleus of different shape. Nucleus of different shape. Now, these lines are important for NEET PG clinical questions, right? Okay. treatment is chemotherapy first. They ask you that why is chemotherapy given first? Chemotherapy is given first because most of the tumors, they are metastatic. When the patient comes to doctor, sorry, when the patient comes to doctor for the first time, most of the tumors would be metastatic. Where? To which organ? To the lungs. Okay. That's important. So first we'll do chemotherapy, then we will do surgery. Ewing sarcoma, aggressive bone tumor. Fine. Now cancer cells have no differentiation. They appear like primitive historical cells, right? Round cells typically have round cells. Most common age is 5 to 15 years. Most common site is femur diaphysis and pelvis. Now, X-ray will show typical onion peel appearance. Now, this one is called as lamellated. Lamellated means in the layers. Lamellated means in the layers. Fine. Onion peel appearance. Laminated or lamellated, both are same. Now, biopsy will show you Homer right nodule, round, circular ones. Gene mutation. There is translocation between chromosome 11 and 22. If you do the immunohistochemistry, you will see that tumor is positive for CD99. And this one is considered to be best prognostic marker. Tumor is radiosensitive. Remember, osteosarcoma is radio resistant, okay? Then multiple myeloma, aggressive bone tumor, most common primary malignant bone tumor. It is seen in elderly males. Most common site is the lumbar vertebrae. Clinical feature, bone pain. Systemic clinical feature, fatigue and anorexia. Last 30 seconds, then we move to 2, 3, 4 questions. Now, X-ray will show punched out lytic lesions. Now, that is called as raindrop skull. Now, very often the queries would come to me, Padibar. Many of the students will send queries that, sir, what is the difference between raindrop skull and salt and pepper skull? So we will write it here today. Fine. You see here. Raindrop skull, salt and pepper skull, salt and pepper skull. So raindrop skull is seen in multiple myeloma. Salt and pepper skull, it is seen in hyperparathyroidism. Okay. Now, you see, buddies, salt is white in color and pepper is black in color. So what you will see in the salt and pepper skull, you will see two things. Lytic areas where the bone is destroyed. Now they will appear black. And you will see, not blastic, you will see sclerotic areas where the bone will appear white, So this is pepper, this is salt. Now, in multiple myeloma, you will just see lytic areas. That means you will just see black spots. I'll show you. See here. So you just see black spot. You don't see any bright white spot. You don't see any bright white spot. Fine. That is the difference between raindrop skull and salt and pepper skull. Raindrop skull and salt and pepper skull. So that's an extremely important point. I mean, I don't know how important it is, but then students, they keep on asking me this. Okay, let me ask you a few questions on the topic of tumors again. I'm just opening that part which has got the questions here. Please bear with me. We are just shifting the pages. Right. Look on your screen and tell me, what do you see? If you want me to write the clinical features, I'll write it here. So your patient is 52-year-old male. History of weight loss. History of back pain. Now, do you find anything abnormal here? Wow, mere sher, Dr. Sanjay ji, cha gaye. Yeah, multiple myeloma is moth-eaten, you can call it. But here also you see something like that only. They have shown it with the arrow also. Very good. So your patient is suffering from tuberculosis of spine. Your patient is suffering from tuberculosis of the spine. And incidentally, tuberculosis of the spine is called pot disease. You see here, the vertebra is destroyed. Vertebra is destroyed. See here. So this kind of vertebra is called vertebra plana, where you see the vertebra is totally destroyed. Vertebra is totally destroyed. Right? Tell me, what is this now? What do you see on your screen? What do you see on your screen? Now, 48-year-old female. 48-year-old female. She presented with a lump in the neck and bone pain increasing with activity. Lump in the neck and bone pain increasing with activity. Lump in the neck and bone pain increasing with activity. Yes, yes, yes. It is osteoclastic lesion, but it is not osteosarcoma. So let me zoom up. See here. Look at this vertebra. The one on the top here. You see here the bone is destroyed. Here the bone is totally destroyed. So that is the lytic lesion. Lytic lesion. Fine. Now this is called as like this. This is called as winking owl sign. That said Dr. Pradipta Roy ji. So your patient had follicular cancer of thyroid and that had gone to the spine. That has gone to the spine. So your patient had follicular carcinoma of thyroid which has gone to the spine. Okay. And there it destroyed the bone. Now this, you see, these are the eyes of the owl. Here, eye. But there is no eye. So that is why it is called as winking owl sign. Winking owl sign. Yes. Now see here also on the opposite side. Here also you see the vertebra is destroyed. Vertebra is destroyed. What is the characteristic thing which you see here? You see here that the intervertebral disc is preserved. Cancer has destroyed the bone, but intervertebral disc is totally preserved. So in cancer, intervertebral disc will be totally preserved, Now see here, one more small discussion, only 20-30 seconds. You see TB, tuberculosis, secondary tumor. They both affect the spine. They both affect the spine, most common organ. And which part of the spine? Dorsolumbar spine. Dorsolumbar spine. Fine. Tuberculosis will affect the anterior part. Tumor will affect the posterior part. In tuberculosis, intervertebral disc is destroyed. In tumor, the intervertebral disc is preserved. That is the main difference between tuberculosis and tumor. Tuberculosis and tumor. Now tell me, what is there in the first image? What is there in the second image? What is there in the first image? What is there in the second image? Both patient came to you with pain abdomen. Both patient came to you with back pain. I'm really sorry. Both patient came to you with back pain. Hanji. Both patient came to you with back pain. Tell me what is there in the first image. Tell me what is there in the second image. Anyone, please? You want me to, or if you please allow me, let me call the names. Dr. Pradipta Roy ji, Dr. Your Drug of Choice Saab, Dr. Sunny Saab ji, Dr. Sravanti ji, Dr. Vinay, Dr. Mehir, Dr. Educate Me. Please try to answer. I'll move forward, don't worry, but please try to answer. Yes, why? So here you see there is a lytic lesion. That means it's a winking owl sign, winking owl sign. But here you see what is there. So here you see there is increased density. There is increased density. So we can call it ivory vertebra also. So ivory vertebra, even though typically seen in Paget disease, it can become, it can be present in metastatic cancer also. So this is the blastic secondary tumor. Blastic secondary tumor. Yes, answer this question, please. Where do you get to see this typical finding in the vertebra? This typical finding in vertebra. Extremely typical finding. Oh, very good, very good. Now this one is called as jailhouse appearance. Jailhouse appearance. Jailhouse appearance or jail bar appearance. Tell me, what is this? What is there in the image number 1 and what is there in the image number 2? What is there in the image number 1 and what is there in the image number 2? Anyone, please? Not giving option, not giving choices, because we just discussed it. That is why I'm not giving option or choices. Okay. Now see, let me zoom up. Dr. Shravanti ji, Dr. Pradipta Roy ji, will you still say it is a simple bone cyst? You see, I don't know whether the image on your screen, how does it say, but there are fine lines visible. There are fine lines visible. So both of them are aneurysmal bone cyst. Both of them are aneurysmal bone cyst. That is the image which we used in the lecture. यही तो फोटो थी lecture में, right? So aneurysmal bone cyst. This one is also aneurysmal bone cyst. Now this is a typical image, aneurysmal bone cyst, finger in the glove appearance. Like this is a typical image of simple bone cyst. Typical image of simple bone cyst extending from epiphysis to metaphysis. Right? Now tell me, what is this? All these images, what cancer do they show? Yes, that is called as trapdoor sign, Dr. Stuti. Tell me, all these images, what do they show? So they all show osteosarcoma, all show osteosarcoma. And what kind of appearance? Sunburst appearance. What kind of appearance? Sunburst appearance. All these images, they show the same sunburst appearance. Now you see this one is showing us Codman triangle. What might have occurred is that the cancer may have grown very, very aggressively, may have grown very, very aggressively, fine? Because the cancer grew very, very aggressively. So what it would be? It would be like this. It would have broken. It would have broken the, oh, it would have broken the periosteum. It would have broken the periosteum, right? It would have broken the periosteum. Please allow me to erase it. Now see, what might have occurred is that the cancer must have grown aggressively like this. And it would have broken the periosteum. It would have broken the periosteum into two parts. Cancer would have grown like this. Now what you see in between, this is the Codman triangle. Codman triangle. Okay. Now, what do you get to see over here? Let me zoom up a little. What do you get to see over here? You see the periosteum is lifted. No, there is a tumor. There is fracture, but what has caused the fracture? Fracture has been caused by a tumor. I don't know whether it is visible, but let me shade something. You see here. So if you can see, this is the lifted periosteum. And if you can see, there is tumor margin also. Tumor margins are visible. The yellow line is showing you tumor margins also. You see the tumor margins. So again, this is also osteosarcoma having Codman triangle appearance. Codman triangle appearance. What do you get to see on the screen right now? What do you get to see on the screen? What I get on my screen is some paratha ad of YouTube. So that you see there are multiple layers. Multiple layers. Here also you see there are layers. So your patient is showing Ewing sarcoma, the typical appearance, onion peel. Fine, onion peel. Yes. So what is this finding? What is this finding? Please tell me. Yes, exactly. Lamellated, that means in layer. What is this patient suffering from? 8-year-old boy. 8-year-old boy. 8-year-old boy. What is this boy suffering from? So you see this image is showing you something extremely typical. Black center, white periphery. Black center, white periphery. Osteoid osteoma. Do any mistake, but never make a mistake while identifying osteoid osteoma. What is this patient suffering from? 18-year-old boy. What is this patient suffering from? Bro, Ewing's would have been here. Diaphysis. It is not here. It is at the metaphysis. And then you again see there is a black center and white periphery. Fine. So this again is osteoid osteoma. What is this showing you? If they show you a bone so badly destroyed and bending like this. So, anyone? Any one of you, if you can tell me the answer. So, it is showing you fibrous dysplasia. Fibrous dysplasia having typical Shepherd crook deformity. Typical Shepherd crook. So this one is Shepherd crook. Typical Shepherd crook deformity. And this is how the chondroblastoma looks like. This is how the chondroblastoma looks like. So it will arise from here and then it will start moving from epiphysis and it will encroach upon metaphysis. Chondroblastoma, typical image also called as Codman tumor, Codman tumor, right? Now, these are the typical tumors, typical conditions which are present at diaphysis. Fibrous dysplasia present at diaphysis. Eosinophilic granuloma present at diaphysis. Metastasis. Adamantioma. Adamantioma typically is present at tibia diaphysis. Leukemia and lymphoma, and then Ewing sarcoma. Ewing sarcoma. Many thanks to the author of this beautiful mnemonic. Okay. Now see here. So round cell tumor. That's another mnemonic for you to remember about the round cell tumor. Round cell tumor. So the mnemonic, you see lemon is round. That is the mnemonic there. Leukemia, lymphoma, Ewing sarcoma, multiple myeloma, eosinophilic granuloma, and it is seen in osteomyelitis and neuroblastoma, also round cell tumors. Okay. Yes. Now answer this question. Super easy question to answer now. Super easy question. जैसे बोलते हैं ना लड्डू क्वेश्चन, इट्स लाइक दैट ओनली. Histopathological examination of tibia diaphyseal lesion returned the following picture. Now, buddies, don't you see the circles forming here? Round cells sitting in circle present at diaphysis. Osteosarcoma will be present at metaphysis. Fine. So answer is Ewing sarcoma, round cells. Here, it's difficult. Okay, this simple question, extremely simple question. The following clinical examination shows you. So what is the patient doing? Patient is performing Fallon test for the examiner. Fallon test, it is used for carpal tunnel syndrome. Entrapment of median nerve. Let us quickly, in 5 to 7 minutes, we will be able to devise all kind of tenosynovitis. I'll just tell you what are the important things. So, Dupuytren contracture is also known as palmar fibromatosis. Most commonly, it affects ring finger. Most common cause is idiopathic. So, idiopathic happens to be the most common cause. Also seen in cirrhotics. Now, this is important for Neet PG. When I say Neet PG, that means in Neet PG also, if they ask you a difficult question, then they will ask you this. Otherwise, just remember this. This is more than sufficient, right? Dupuytren contracture, hand of your patient will go like this, okay? Now, flexion deformity. Now, I've already told you that most common affected is ring finger, okay? Treatment will cut it and it will again become straight. If the flexion exceeds 30 degree, right? De Quervain disease. De Quervain disease is inflammation of two tendons and the tendon sheath. De Quervain disease. Now their names are important. Anatomical snuff box tendon, APLEPB, abductor pollicis longus, extensor pollicis brevis. Fine, De Quervain disease. That is the only thing important here. You just need to remember the names. Please do, right? De Quervain disease. Now here, they used to perform an old style test, obsolete test, which is not done now. Identify this if they ask you. So the name of this test is Ishkoff test. Ishkoff test. Now this is the hand of doctor. This is the hand of patient. What will the doctor do? Doctor will forcefully twist the wrist like this. Forcefully twist the wrist, and there will be severe pain over here. Severe pain over here. Not done now. Now what is done is called as Finkelstein test. Finkelstein test. Hand of the doctor. Thumb of the patient. Thumb of the patient. Right? So you ask the patient to do the deviation, twist the wrist himself. Now, when there is too much pain, patient will stop. Then we ask the patient to close the fist. And patient himself will do the rotation, not the doctor. So there will be pain over here. There will be pain over here, right? So this is Finkelstein test. Finkelstein test, right? Done in 2 steps, but usually in the exam, they ask you this image. Find Finkelstein test. Okay. Trigger finger. So clicking noise on flexion and extension of finger. Tuck, tuck ki awaaz aayegi, right? Now, you see there is a nodule. This nodule, when it enters the sheath and when it comes out, it will give sound. It will give sound. Trigger, finger. Okay. Now, treatment is excision of the nodule. Here, tennis elbow. Inflammation of extensor muscles which are seen at the lateral condyle, Now for Neet PG, you must remember this name, extensor carpi radialis brevis. That is the most common muscle affected. Test is Colles test. Colles test. So this is the hand of the patient. We ask the patient to do like this, but doctor will try to stop, will apply force. Colles test. Colles test. Fine. The other test is Maudsley test. So again, patient will be asked to lift the finger up. Doctor will stop this motion. There will be severe pain, right? Severe pain. Treatment is NSAID braces or autologous blood injection. No steroid. If the answer shows steroid as the options, don't tick steroids because the steroids can break the tendon. Steroid can break the tendons. It will make the tendon very, very thin, right? So, tennis elbow. Opposite word is golfer elbow. Opposite word is golfer elbow. Now you see it has got so many names. It is called as swimmer elbow. It is called as baseball elbow. Loosely connected to little leaguer elbow. Also called as climber elbow. Also called as suitcase elbow. Also called as forehand tennis elbow. Fine. So exactly opposite to the tennis elbow. So tennis elbow is affecting the lateral side. Golfer elbow will be affecting the medial side, For Neet PG, you must remember the name of this muscle. Flexor carpi radialis. Test is reverse cousin. Everything else is the same. Javelin thrower elbow is acute injury to the ulnar collateral ligament. Right? Acute injury here. Acute injury to the ulnar collateral ligament. Carpal tunnel syndrome. Of course, many of you already know. So it will be entrapment of median nerve below the flexor retinaculum. Now, clinical features. Pain increases with activity. That means the pain will be worse at night. Patient becomes clumsy, begins to drop object. Now, there will be weakness of these muscles. Now, these muscles are called thenar muscles, common in women. Most common cause is idiopathic, but this is associated with rheumatoid arthritis, hypothyroidism. Now, if you tap on the nerve, same symptoms patient will have. Tunnel sign, tapping on the nerve. You ask the patient to do the flexion of wrist like this. That is called as Fallon test. Now, when you ask the patient to do the flexion of wrist, median nerve is compressed. Right? Median nerve is compressed. Reverse Fallon test. So, buddies, this one is Fallon test and this one is reverse Fallon test. Wrist in extension. Okay. So, if the wrist is in extension like this, you see, this is wrist joint in extension, also called as dorsiflexion. So extension and dorsiflexion are same. Here you see the wrist joint is in flexion, also called as palmar flexion, right? Okay, treatment is basically physiotherapy or removal of the flexor sheath, right? Tarsal tunnel, you just need to remember the name of nerve, posterior tibial nerve. Okay, right, buddies. Now, let's have a look at few important x-rays. Now, you see boxer fracture. Very quickly, we'll have a look at few important x-rays. You see boxer fracture is fracture of fifth metacarpal neck. Boxer fracture. What is the other name of boxer fracture? It is called as brawler fracture. Right? Now, mallet finger. You see, mallet finger might occur as a result of fracture also. So, I'm showing you this part of my finger. Fine. So, this part of the finger is called posterior aspect. This is also called as extensor aspect. This is also called as dorsal aspect. So what is mallet finger? What has happened here is that the tendon is broken. Here. but the flexor tendon is perfectly working. So it has pulled the finger like this. Okay. So mallet finger, it occurs due to rupture of extensor tendon. Extensor tendon. Can anyone tell me what is the other name of mallet finger? What is the other name of mallet finger? So mallet finger is also called as rugby finger. Is also called as rugby. No, sorry, I got it wrong. Sorry, I got it wrong. It is called as baseball finger. I'm really sorry. I got it wrong. Mallet finger is also called as baseball finger. I stand corrected, please. People make mistakes. I stand corrected. So it is also called as baseball finger. The opposite one is called as jersey finger. Opposite one is called as rugby finger. Now that one is due to the rupture of flexor tendon, right? Treatment for both is surgery. Fine. But let's say if they ask you the name of the splint, and I'll show you that splint also. Fine. Now, the name of the splint is Stack's splint. So Stack's splint is for mallet finger, whereas for jersey finger, name of the splint is frog splint. Fine. Stack's splint. And I'll show you that. I'll show you the images of splints shortly. Right? You see mallet finger. Now, tell me what is the name of this fracture. Please tell me what is the name of this fracture. Anyone? What is the name of this fracture? Yes, Dr. Mansi. So if you can see, there is a tibial plateau fracture. Anyone, please? I'll not give option because otherwise you'll come to know that. Okay, I'll give you option. Whether it is a Bennett fracture, whether it is a Seagon fracture, whether it is a Tellox fracture, fine, or is it a bumper fracture? So you see there is a big fracture. If you see such a big fracture, it is called bumper fracture. See, adults, the height is like this, that the car will strike here, right? Bumper fracture. Here you see. So adults, it will strike here. The car will strike here. Now in young children, the teens, it will strike here, mid of the femur. Now in children, it will strike the hip joint, bumper of the car. What is this fracture? Identify. I'll zoom it up for you to identify where is the fracture. See, here is the fracture. And that's a very important fracture. Here, can you see the fracture? The images are so typical that I don't feel like giving you the options. Because you see, that's a very typical image. Tell me. Okay, I'll ask you an easy question. Is this patient suffering from osteoarthritis or not? So you see the joint space on both sides is normal. It is not reduced. So this patient is not having osteoarthritis, but there is a fracture over here. And this kind of fracture is called C-gond fracture. Very, very important kind of fracture because this is associated with anterior cruciate ligament injury. This kind of fracture is associated with ACL injury, anterior cruciate ligament injury. Fine. ACL injury. Now, another fracture which you should see is the chance fracture. Chance fracture. Fine. Chance fracture is also called as jackknife fracture. Now, what is the reason here? See. Now, so this fracture is common if your patient is wearing the seat belt. When your patient wears the seat belt, the spine goes in acute flexion. Spine goes in acute flexion. So anterior part of the vertebrae collapse and posterior part of the vertebrae, they separate from each other. Chance fracture, also called as jackknife fracture. Now, this kind of fracture is extremely unstable. Anterior part of the spine fracture, middle part of the spine fracture, posterior part of the spine fractured. The only thing is anterior part goes like this and posterior part it goes like this. Chance fracture, also called as jackknife fracture, also called as jackknife fracture, right? Now, the image. Let's say, buddies, now these are metatarsal bones, right? And these are tarsal bones, tarsal bones. Now, this red line is showing you Lisfranc joint. So Lisfranc joint is basically tarso of fish. It's showing you tarsometatarsal. It's showing you tarsometatarsal joint. Lisfranc joint is showing you tarsometatarsal joint. Fine. So let me just color it up here. So you see these are the tarsal bones, the yellow colored ones. Tarsometatarsal joint. And these tarsal bone, tarsometatarsal joint. If there is disruption here, that will be called as Lisfranc fracture, Lisfranc fracture, right? And if there is disruption between the chop-part joint, so you see the chop-part joint is between talus, calcaneum, and the rest of the tarsal bone, rest of the tarsal bone, right? See here, chop part fracture dislocation. So chop part fracture dislocation is called mid-tarsal dislocation, is called mid-tarsal dislocation, right? If you don't want to remember the details, perfectly okay. Just remember chop part fracture is mid-tarsal fracture. Now see here, mid-tarsal. So this is showing you chop part, mid-tarsal, chop part fracture, chop part fracture. Here if you see, fine, there is dislocation in the middle of the tarsal bone from here to here, tarsal, and then we have got metatarsal. So you see tarsal, metatarsal, right? Lisfranc injury, Lisfranc injury. Fine. So where you see the metatarsal separating from the tarsals, Lisfranc injury, Lisfranc fracture, right? You see here. in this circle, there is fracture, right? So metatarsal bone separating from the tarsal, Lisfranc fracture, pot fracture. So you see, pot fracture is an important fracture. Pot fracture is bimallular fracture, bimallular fracture. So if you see in this image, the lateral malleolus fractured, medial malleolus fractured, right? Pot fracture. Now, pot fracture, right? Now, this is how the fracture can occur. Whereas cotton fracture, lateral malleolus fractured, medial malleolus fractured. Now, this is antero-posterior view, and this one is lateral view. So if you see fracture of posterior malleolus also, if you see the fracture of posterior malleolus also, then this fracture is called trimalleolar fracture. So pot by cotton tri. If anyone of you has got a mnemonic, अभी तो चाय से गुजारा करना पड़ रहा है भाई. If any one of you has a mnemonic for this, please share. Pot and cotton. I'll do that. I'll do that, Dr. Beauty of Berin. I'll do that. I'll do that. So this is lateral malleolus. This is medial malleolus. This is posterior malleolus. Now, Gosselin fracture, not so important here. Now, toddler fracture. Toddler fracture is important. You will see that there is a spiral fracture in tibia. You will see that there is a spiral fracture in tibia. Just give me a minute, guys. 1 minute. There's some problem on my screen. Let me share it with the team. Okay. Toddler fracture is a spiral fracture. It's a spiral fracture of tibia. So it is a spiral. You see here in this, let me show it with a different pen. It is a spiral fracture. Spiral fracture of tibia. Spiral fracture of tibia. Toddler fracture. Right? So it will occur because of twisting of the bone. Because of twisting of the bone. Right? Pylon fracture. Yeah. Holston-Lewis fracture. That's an important fracture here. Holston-Lewis. That is the fracture of proximal 2/3 and distal 1/3 of humerus, right? Of humerus. And what happens here is that the radial nerve is trapped. Radial nerve is trapped. There is injury to the radial nerve. Okay. Tillot's Chopert fracture. Tillot's Chopert fracture. So the medial end of the tibia is fractured. Medial end of the tibia is fractured here. Right? Medial end. Now, Lefort fracture is the reverse. Is the reverse of the fracture which we just saw. Is the reverse of Tillot's fracture. Is the result of Tillot's fracture. Fine. So, Tillot's fracture was affecting tibia. Leaf foot fracture will affect the fibula. Okay. Seagon fracture we have already seen. Shepherd fracture. So Shepherd fracture will affect the talus. It will be a small chip fracture, small chip fracture. Important image. Fine. Now, straddle fracture. Straddle is the seat of the horse. So that will affect the pubic bones. Straddle fracture. Again, not so important, but then they can ask you. Jefferson fracture. So you must see about the Jefferson fracture, that is the burst fracture of atlas. C1. Fine, burst fracture. Fragments, they will go outwards. Fragment, they will go outward. And here in between would be present the spinal cord. Now, the X-ray, we see it like this. Open mouth odontoid view. Open mouth odontoid view. Right? Okay. Hangman fracture. Important. So C2, it slips over C3. C2 vertebra will slip over C3 vertebra. Hangman fracture. Hangman fracture. Right? Hangman fracture. Clay shoveler fracture is fracture of C6 and C7. It occurs due to abrupt flexion. It occurs due to abrupt flexion. Fine. So remember, hangman fracture, C2 will slip over C3. Fine. Clay shoveler, C6, C7, posterior fracture. Let me show you how. See here. So if there is abrupt flexion, right, then there will be a fracture here. Then there will be a fracture here, like this. Like this, abrupt flexion. Right? Then a similar fracture which occurs at C6, C7, that is called as undertaker fracture. Undertaker fracture, again it affects C6, C7, but this is seen in the dead people. So when they are buried down in their graves, if the dead bodies are not handled properly, posterior part will sustain injury. Posterior part will sustain injury. Right? Okay. Now, what do you see on your screen right now? So this patient happens to be 27-year-old male complaining of back pain. Complaining of back pain. What do you see on your screen right now? Make the diagnosis. What condition is your patient suffering from? Very good, doctor, your drug of choice. Doctor, your drug of choice, you have been giving really nice answer. Maybe know your name, please. Because when I say, doctor, your drug of choice, so that becomes a long statement. So I thought maybe you have got a small name or nickname type. No, this is not a dagger spine. This is not a dagger spine. Yes, definitely the diagnosis is ankylosing spondylitis, but this is not a dagger spine. Now, what you see here is that you see white lines on both sides. Oh God, why is this coming in between? So you see white line on both sides. You see white line on both sides. Let me just draw. Here, you see white lines. So this is not dagger sign. This is railroad sign. If you see white lines on the side, That is called as railroad sign. Dr. Stuti, bamboo spine is just the fusion of vertebra. But if you see white lines on the side, that is railroad sign. Let me erase. Now see. Let me zoom up for you. Now see. Let me zoom up for you. Right? So if you see bright white lines on the side, fine, then that means you are dealing with railroad sign. Railroad sign. Just give me a minute. Okay, now here, this is called as bamboo spine. The first one is bamboo spine. Now, what do you see in the second image? In the second image, you see another typical finding. In the second image, you see the squaring of vertebrae. You see the squaring of vertebrae, right? And then you see syndesmophytes. You see the syndesmophytes. Okay. Now here, what sign do you see now? You see a line in the middle. You see a line in the middle. Now this line which you see in the middle, now this line is called as dagger sign. Now this is called as dagger sign. If you see a bright white line in the middle, this will be called as dagger sign. See, again this, now what sign do you see? Watch closely. You see faint white line on the sides also. You see faint white lines on the side also and in the middle also. So this one, what you see now is trolley track sign. Trolley track sign. Trolley track sign. So if you see white lines in the middle as well as in the center, that means you are dealing with trolley track sign. You're dealing with trolley track sign. Okay. Right. Let's quickly read about all the different arthritis. All the different arthritis. See, rheumatoid arthritis. It is an autoimmune disease. It is associated with HLA, DR1, DRW4, and even 8 also. Now, some virus, Epstein-Barr virus. Now, what is the main pathology? IgM antibodies, they develop against IgG immunoglobulin. So that means, practically speaking, IgG is the antigen and IgM is the antibody. So IgG plus IgM, now what are they called? They are called immune complex. Now they start inflammation. They start inflammation. Okay. The first site of inflammation is synovium, and it is caused by interleukin 10 tumor necrosis factor alpha. Fine. Interleukin 1, sorry. Interleukin 1. Now, inflamed synovium is called pannus. Most common pattern is symmetrical polyarthritis, and most common joint is metacarpophalangeal joint. Let's call this MCP. Remember, MCP joint is typically spared in osteoarthritis, is typically spared, not involved in osteoarthritis. Thank you, Dr. Vigilance G. Then, see here, minimum 4 joints must be involved. Minimum 4 joints must be involved. Next joint is PIP joint. Then DIP joint is characteristically spared, not involved. DIP joint is not involved. Less common joint, hip joint. Remember, hip joint is the most common joint in osteoarthritis. Most common joint in the osteoarthritis. Fine. So when I say minimum 4 joints, fine, that's 5 or equal to 5. Okay, must be involved. Now, all the organ systems are affected. In the lungs, interstitial lung disease. Eyes, they become dry. Your patient develops pleural effusion, right? Myocarditis. Your patient will develop fever. Rheumatic nodules, they develop on the extensor surface. Rheumatic nodules, they develop on the extensor surface, right? Most common site is olecranon. That's a question. Twice or thrice they ask. Now, the different deformities. I could have asked you like this as a question, but let's quickly revise them. So you see here at the DIP joint, there is flexion. At the PIP joint, there is hyperextension. See, buddies, at the DIP joint, there is flexion. And at the PIP joint, there is hyperextension. So this one is swan neck. Swan neck. Okay. Then DIP joint, you see, if there is just flexion at the DIP joint, that is called as mallet finger. Now, reverse. If there is hyperextension at the PIP and flexion at the, hyperextension at DIP and flexion at PIP, that is called as boutonniere deformity. Flexion deformity at the toe, hammer toe. Fixed extension deformity. But you see, this is flexion of the thumb, or we can also say adduction. But this is extension of the thumb. My hand is like this. Extension. Extension. What happens here is hyperextension. Hyperextension. So hyperextension is, called as hitchhiker thumb. Hitchhiker thumb. Hitchhiker is someone who asks for a lift. Someone asking for a lift. That is hitchhiker thumb. Okay. Piano key sign. When the joint between ulna and radius is broken, you can press radius and ulna like the keys of piano. Investigation. RA factor is high. The problem with RA factor is that it is non-specific. It is non-specific. It is raised in other condition also. The second problem, when the disease is waxing, that means patient condition is getting worse. RA factor will be very high. But when the disease is waning, that means patient is improving. Then RA factor will be very, very low. Okay. Then what is the specific antibodies? So they are anti-CCP, anti-CCP, anti-cyclic citrulinated peptide antibodies. Now they are also called as anti-citrulinated peptide antibodies. Treatment is NSAID and DMARDs. Now many thanks to the producer of this image mnemonic. Beautiful one. So that gives you a mnemonic to remember rheumatoid arthritis drugs, right? Magic pills. If you don't want this mnemonic, there is another mnemonic. Eliza, please give her methotrexate, because methotrexate is the drug of choice. Your drug of choice, भाई साहब, आपका नाम आ गया फिर से. Fine, drug of choice, methotrexate. So that is a way to remember. Now, rheumatoid arthritis is associated with Felty syndrome, splenomegaly, anemia, neutropenia, thrombocytopenia, and arthritis, right? Felty syndrome. They ask you question, what is the first sign? Juxta-articular osteopenia. यहाँ पे हमारे डॉक्टर साहब ने कुछ कहा था, एकदम से याद आया. डॉक्टर ब्यूटी ऑफ बहरीन भाई साहब, see, you have asked about chondromalacia of patella. So that is a degenerative condition. See, on X-ray, beauty of Bahrain, bhai sahab, on X-ray, what you will see is just degenerative changes which are seen in osteoarthritis, right? Chondromalacia patella is also called as runner's knee, right? So the investigation of choice there is MRI, not the X-ray. Because if you see X-ray, the only thing you might see is osteoarthritis, changes of osteoarthritis. Fine, I'll show you that, but the findings are not specific there. You'll just see the changes of osteoarthritis. Okay, very quickly, the second one, osteoarthritis. It is not an inflammatory condition, it is a degenerative condition, right? Common in males, okay? It is common in obese. Why common in obese? Because in obese people, there is too much pressure. There is too much pressure on the knees, too much pressure on the knees of your patient. Okay. Now, secondary arthritis, when cartilage in the joint is destroyed by some other disease and not by aging. What are the common diseases which destroy the cartilage? Septic arthritis, rheumatoid arthritis, and intra-articular fracture. Intra-articular fracture. See here. Let's say there is intra-articular fracture. Before the fracture, you see the cartilage is smooth. Now let's say the fracture has occurred. Let's say there has occurred a fracture like this. Okay. Now, buddies, when the healing will occur, when ultimately the healing of the fracture would occur, bone will heal, but the cartilage will not heal. Bone will heal, but the cartilage will not heal, and it will become rough. It will become rough, right? So it can cause osteoarthritis. Now, what the question they ask? What is the most common joint to be destroyed by osteoarthritis? You see, we Indians are totally different from the rest of the world. So, most common joint around the world is the hip joint. But in India, most common joint is the knee joint. In India, most common joint is the knee joint. Okay, clinical feature, there will be pain. That's not important. Now, the cartilage is destroyed on medial side first. Cartilage is destroyed on medial side first. So you see here, let me see, this is the medial side of both bones, femur and tibia. So what happens is medial side of both bones, they come very close to each other. Lateral sides cannot come close to each other because in between them, cartilage is present. In between them, cartilage is present. Cartilage is present in between them, right? Because the cartilage is present. Now, this will give rise to typical deformity called, see here, like this. So there is an O forming. So this will give rise to genu valgum. So genu valgum is seen in osteoarthritis. Genu valgum is seen in osteoarthritis. See, both of the feet, they are going towards midline, Osteoarthritis, right? Genu varum. Okay, now here, metacarpophalangeal joint is spared, important, right? Proximal interphalangeal joint is inflamed. Proximal interphalangeal joint is inflamed. It is called as Bouchard node. Distal interphalangeal joint is inflamed. It is called as Hepburn node. Right? X-ray will show asymmetrical loss. So you see, buddies, here there is loss of space. Here, the joint space is normal. Asymmetrical loss of joint space is seen in osteoarthritis, right? Then eburnation, bone will rub against bone. And here what will happen? Osteophytes will form. Right? Now, osteophytes. The bone edges, they become rough. Osteophytes form. Investigation. Arthroscopy. Fine. Artho means the joint. Scopy means the camera. It will show loose bodies. Now, the question, what is the most common cause of loose bodies in the joint? Osteochondritis dissecans. What is the most common cause of loose bodies in the joints in elderly? Osteoarthritis. Treatment is weight reduction. Gold standard treatment is joint replacement. But try telling this to your patient. They will not agree. They will say, Doctor साहब कोई दवाई दे दो, दवाई से ठीक कर दो. Right? So imagine today in the OPD, one patient who had hernia, he came to me and the patient claimed that there is a Baba who can heal the hernia without surgery. I said, you are at the wrong place then. Making the patient agree for surgery is very difficult. Okay, psoriatic arthritis. I have been telling this for the last 6 or 7 years that this is associated with HLA-B27. Many other diseases are associated with HLA-B27, right? Not just ankylosing spondylitis. सिर्फ ankylosing spondylitis नहीं है B27 के साथ, बाकी भी बहुत सारी बीमारियां हैं. Reactive arthritis. It was there in this question this year, right? Juvenile arthritis. Now, male-female incidence equal. Now, you see in the psoriasis, what do you get to see? You get to see silvery scales. You get to see oncolysis, right? Nail destruction. You get to see swollen fingers. They are called as sausage fingers. On X-ray, you get to see pencil in the cup. Appearance. So you see this is the pencil tip and this is the cup. Pencil in the cup appearance. Right? Okay. Now see here. So what happens is that there is severe osteolysis. Bones are severely destroyed. When they are pulled, the fingers, they become slightly longer, and when we leave, they become slightly shorter. This is called as telescoping of fingers. Telescoping of fingers. We get to see folds on the hand because the fingers, they have become small. We get to see folds on the hands. Now they are called opera glass hand, opera glass hands, right? Treatment is infliximab is a thioprin, or you can simply use NSAIDs. Ankylosing spondylitis we have studied. I'll just enumerate the important points. So it is associated with HLA B27. Primary site is anthesis. Fine. One thing I forgot to mention here, in ankylosing spondylitis, there is limited chest expansion. You see, when we take deep breath, the chest expands, but here it does not. Limited chest expansion. Squaring of vertebra. See here. Squaring of vertebra. So this vertebra is absolutely normal. You see, it is concave, it is round. But then all other vertebra, you see, they are straight. They are straight. Fine. So that means there is some problem here. Fine. So that is squaring. So squaring is seen in ankylosing spondylitis, right? Ankylosing spondylitis. Now, that's another one-liner. Squaring of patella is seen in which condition? It is seen in hemophilia. Now, here, you see, you don't see any specific white line. Now, it is showing you fusion of vertebra. That is why it is showing you the bamboo spine, right? Bamboo spine. Now, the ligaments around the spine, they are also inflamed. They are also calcified. For example, ligament covering all the spinous process, calcified it is. That is called as dagger sign. So if you see a white line in the middle, that is dagger sign. Now, if you see white line on the sides, that is called as railroad sign. So we see white lines on the sides, white lines on the sides. Now, if we see white lines on the sides and white line in the middle, that is called as trolley track sign. Now, treatment is NSAIDs and infliximab. Now, this disease, it starts at the level of sacroiliac joint. Now, for sacroiliac joint, the test name is Ganselan test. Now, Ganselan test is also known as Faber test, is also known as, sorry, these are the other tests, I'm sorry. The other test are Faber test, also known as Patrick test, also known as figure of 4 test. For lumbar spine, name of the test is Scober test. Now, extra-articular, that means not involving bone and joint, not involving bone and the joints. Okay, so uveitis, iridocyclitis, cataract, glaucoma, inflammatory bowel disease, IgA, nephropathy. So these are the diseases which are commonly associated with ankylosing spondylitis, ankylosing spondylitis, right? Okay. Now I believe we have some 2, 3 questions left. Let's see we can do that or not. Yes. Tell me the name of this splint. Super easy question. I know in exam they will not ask you these easy questions. But tell me the name of this splint. Tell me the name of this splint. Anyone? Super easy. At times we may forget things, but please tell me the name. Are you guys there? Why can't I have your messages? Chat is blocked or what? Dennis Brown splint. Dennis Brown splint. It is seen in club foot. Fine. Now, what is the name of this splint? What is the name of this splint? And for what fracture is this used? This is not a splint basically because it is covering all around. This is covering the limb 360 degree. This is covering the limb all around. So this is the cast. What kind of cast it is? Just give me a minute to minimize this. What kind of cast this is? This is a patellar tendon bearing cast. Patellar tendon bearing cast. Fine. This is for the tibia fracture. This is for the tibia fracture. Patellar tendon bearing cast. Right? You see here. So this is short leg cast. This is cylinder cast, also called as tube cast. And if it goes beyond the knee joint and goes into the thigh, this will be called as long leg cast, right? Now, these are the common site of malunion. What is the mnemonic? MISC. Fine. MISC. Common site of malunion. Intertrochanteric fracture of femur. This is also called as extracapsular fracture of femur. Supracondylar fracture of humerus. Now, this will give rise to gun stock deformity. Gun stock deformity. Right? Gun stock deformity. Colles fracture. This will give rise to dinner fork deformity. And clavicle fracture. Remember, clavicle is the most common bone to get fractured. Okay. Now, floods. That happens to be the most common, the most common sites of non-union. Most common site of non-union. Right? Now here, femur neck fracture, that means the intracapsular fracture, lateral condyle of humerus fracture, lower 1/3 of ulna, body of talus, body of tibia, scaphoid. Acha, if you don't want to remember too many, just remember this, this, and this. Important ones, right? Okay. Causes of monoarthritis. Many thanks to the creator of this mnemonic. So, monoarthritis, that means a single joint is affected. Okay. So, gout. hemarthrosis, osteoarthritis, sepsis, trauma, right? So these are the common ones, common causes of monoarthritis. Fine. Arthritis involving single joint, right? We'll do that. Now, the red flag signs of back pain. Red flag sign means there is something serious. There is something serious. Red flag sign means there is something serious. The back pain is not normal back pain. Some serious condition is there. Fine. So these are the, mnemonics there. Mnemonic to remember. There might be severe trauma to the spine, unexpected weight loss. It will occur in tuberculosis or tumor. Neurological symptoms that will occur in tuberculosis, that will occur in tumor, that will occur in slip disc, that is PIVD, prolapsed intervertebral disc. Age more than 50. Any patient who is more than 50 will have chances of cancer. Chances of cancer. Your patient has fever. That means there could be infection like tuberculosis. Fine. That is intervertebral disc. Intervertebral disc prolapse. S is for steroid use. History of cancer. So that tuna fish, that happens to be a mnemonic for red flag signs of back pain. Red flag signs of back pain. Fine. Red flag signs of back pain. Okay. So here, I was checking this mnemonic. It says intravenous disc use, intravenous drug use. It is not related to the disc. That's a mnemonic actually. So I just wanted to share with you. Intravenous drug use. So your patient could have septic arthritis. Okay. Now, identify this cast for me. Splint, sorry. You see, it is not covering 360-degree. So this is not a cast. This is not a cast. This is a splint. This is a splint. Okay. Now, what kind of cast is this? That is what kind of splint? That is a static cock cup splint, not moving. Static means not moving. Now, this one is dynamic cock cup splint. Dynamic cock cup splint. Fine. Now that is useful for which nerve injury? Radial nerve injury. Useful for radial nerve injury. Now, you have to identify this device. So this device is SOMI brace. SOMI brace. SOMI brace. Fine. You have to identify this device, SOMI brace. Okay, important there. SOMI brace. Yes. Identify this condition. Can any one of you please answer this for me? The question which you see on your screen right now. The question which you see on your screen right now. So this is seen in made-lung deformity. Made-lung deformity. Not very important. Let's skip this. Now, please identify this for me. Typical sign. Typical sign. And this is not enchondroma. Because enchondroma, you see, it's not there in the options. the following finding can be seen in? So, dear doctors, what you see on your screen, they are called brown tumors. Now, brown tumors are seen in hyperparathyroidism. They are seen in hyperparathyroidism. Brown tumors. Yes, please try to answer this question. Please try to answer this question. 9-year-old child attending orthopedic clinic presents with pain in the hip joint, which increases by activity. X-rays were taken which returned the following picture. What is the likely diagnosis? Even though the image is extremely typical, but you people are so fond of options, I've given you the options also. Now please give the right answer. Now please give the right answer. Dr. Muhammad Talib ji, in osteopetrosis, what is the other name of osteopetrosis? Marble bone disease. The bone will appear bright white in color, like this. Like this color, bone will appear. Remember, osteopetrosis, what is the other name? It is called as marble bone disease. Right? Anyone, please? I'll now start calling name. Dr. Heels. Doctor, your drug of choice, Dr. Jasmine, Dr. Praveen ji, डॉक्टर एल्कोहलिक, चलो आप भी बता ही दो. डॉक्टर स्तुति, डॉक्टर दीप्ति, डॉक्टर सेतु. अच्छा, ओके 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 ओके, सॉरी सॉरी सॉरी, माय बैड माय बैड. बट प्लीज टेल द आंसर ऑफ दिस क्वेश्चन. मोहम्मद तालिब भाई, इसका भी बताइए आंसर प्लीज. एनीवन? सो भाई देखो, ऐसे मत करो यार प्लीज. यू हैव ऑल रेड दिस. व्हाट इज दिस? Your patient is suffering from Perthes disease. Now, Perthes disease is avascular necrosis. Avascular necrosis. Now, common between 6 to 10 years of age. Common between 6 to 10 years of age. So, we get to see crescent sign. Fine. We get to see bite sign. We get to see gauge sign. So what you see over here is something which is called as bite sign. Bite sign. Right? देखो जी. Either you guys are tired because इतने लड्डू क्वेश्चन का अगर आपने आंसर नहीं दिया तो गलत है. See here. What you see over here is called as bite sign. Is called as bite sign. Very important. Okay. Okay. Now see, the common age of presentation of the following condition is. Common age of presentation of the following condition is. The prepubertal is less than 10 years. Peripubertal is 10 to 14 years. Okay, at least identify the condition. So you see here, buddies, your patient is suffering from slipped capital femoral epiphysis. So answer is peripubertal. 10 to 14 years of age is the common age. Slipped capital femoral epiphysis. Now, this is the normal femur. Now, here you see the epiphysis is separated from physis and metaphysis, right? Epiphysis is separated from physis and metaphysis, right? Now, Slipped capital femoral epiphysis. Please tell the answer to this question. 40-year-old male presented with history of roadside accident. Fine. The clinical feature includes, see what has happened here. The femur has gone posteriorly. Femur has gone posteriorly. So, buddies, what is your patient suffering from? Your patient is suffering from posterior dislocation of the hip. Posterior dislocation of the hip. You people are not answering. Probably we need to study the hip joint very, very quickly. Just give me a minute. Let me check. Yeah. We'll do this very, very quickly. Quick revision of the hip joint. Right? Now, see here. Hip joint is an extremely stable ball and socket type of joint. Right? Now, femur head and acetabulum. FH means femur head. A means acetabulum. They have got same size and similar shape. Then there is a joint capsule. There is a joint capsule. Right? Now, we shall start with the first thing, DDH, developmental dysplasia of the hip joint. So, DDH is most common congenital orthopedic disorder around the world. But in India, it is the second most common. What is the most common congenital orthopedic disorder in India? That happens to be club foot. That happens to be club foot. Okay. Now here, what is the problem? Acetabulum is flat. Femur head is also flat. See, buddies, listen to me. For those who have not studied this topic, what happens is, I'll start. Perfect hip joint is made up by two bones, very round acetabulum and very round head of femur, right? But inside mother's body, when the joint is forming, acetabulum is flat, femur head is flat. And the joint is not a strong joint. What happens is, when the baby opens the legs inside the mother's body like this, what happens is when the baby opens the legs inside mother's body, femur head enters acetabulum. Slowly, what will happen is femur head will become round. Acetabulum will become round like this. But what if the baby is not able to open his or her legs like this? Now, in the first image, you see normal baby. And in the second image, you see breech baby. Now, breech baby will not be able to open her legs, will not be able to open her legs. Now, when this baby is not able to open her legs, hip joint will not form. Hip joint will not form properly. Okay. Now, the question, see, why it is not common in India? In India, the mothers hold the baby like this. Legs of the baby are spread wide apart. बच्चे की टांगे एकदम चौड़ी करके रखी हुई है मदर ने. Fine. Legs of the baby are spread wide apart. There is wide abduction. So even if a child is born, he will get corrected. he will get treated automatically at home only. Now, so about this disease, there are 5 F's. Family history. Females, the disease is common in females because they have got lax ligament. Of course, you people know the meaning of the word lax. Lax means loose ligament, loose ligaments. Okay. It is common in the firstborn because you see, firstborn, there is tight space. Uterus is small, abdominal muscles are tight. So there is no space for the baby to move, right? It is common in the foot first delivery, that is breech delivery, because there is no space for the baby to move. For the baby to move, there is no space. Okay. F. It is common in fluid disorders like oligohydramnios. But surprisingly, this is not very common in twin pregnancy. Okay. Now, in Neet PG, they will ask you what kind of breech. So you see first, second, and third. It is more common in the frank breech. You have had gynae classes, I believe, right? So you know by now what is the frank breech. So it is more common in frank breech, right? What are the clinical feature? If you understand this image, you will be able to understand rest of DDH. What happens is that the femur head, entire femur bone is pulled up. Entire femur bone is pulled up like this, is pulled up like this. Okay. Now, because the femur bone is pulled up, child will not be able to touch the heels with the ground, will not be able to touch heels with the ground, right? Okay. I'll do that, Dr. Lazy Medic. I'll do that. Definitely. Next topic is infections only. We'll do the infections. Our next topic is infections only. I'm here with you guys all the time. I'll do that. Right? So, because the femur bone is pulled up, by the muscles. See, in normal people, what happens is that the hip joint is very strong. Here, in the patient of DDH, hip joint is very weak, can be easily broken. Fine. So femur can be easily pulled away from the hip joint. Dr. Lazy Medic, I seems you have watched the previous year or previous 6 months of orthopedic lecture. Can you please tell me which other topic I did not discuss in that lecture? I'll try to discuss them in this lecture only. Thank you so much for your feedback. Now, because that actually helps us to deliver slightly better. So because the femur is pulled up, the feet of the baby will not touch the ground. So there will be apparent shortening. और चलो राजू जी सही सही लगा लो आप हमारे साथ हैं अभी, तो डॉक्टर बना देंगे आपको. Greater trochanter, right? So the muscle, they will pull it up. Now, not important. Yes, Barlow test and Ottolani test. So Barlow. So what is Barlow test? Dislocation of femur head out of the acetabulum is easy and occurs with Minimal force because the hip joint is weak. You can easily separate acetabulum from femur. Otolani test. Relocation of femur head into acetabulum is easy. Khan Sahab, 19. What is 19? 19. Relocation of femur head into acetabulum is easy. That means femur head can go in, come out of hip joint easily. खान साहब मेरे बस का होता तो मैं बिना पढ़ाए आपको, सॉरी, बिना एग्जाम दिलाए ही आपको 200 नंबर दे देता. Okay. Now, what do we get to see on the X-ray? So on X-ray, we have to see something which is called as Shenton arc. Shenton arc. So we draw a line on the medial border of femur. And then we draw a line on the lower border of pubis. Lower border of pubis. And the line does not meet. Line does not meet. Now, this is called as broken Shenton line. This is called as broken Shenton line. Broken Shenton line. Oh, that's terrible, Raju ji. Okay, what are the investigation? 6 months, 0 to 6 months of age, investigation of choice is ultrasound. More than 6 month investigation of choice is MRI. What is the problem with MRI? MRI requires sedation. MRI requires sedation. And sedation is not safe. Sedation is not safe for small babies. Is not safe for small babies, right? 0 to 6 months, the treatment is Pavlik harness. Buddies, you must see this image. Absolutely important, right? Van Rosen splint is hard, therefore it is not used these days. Not used these days. 6 to 18 months, the treatment is surgery, open reduction. 18 to 36 months, the treatment is femoral osteotomy. Fine. Question, important, Neet PG. 3 to 6 years, treatment is acetabular augmentation. 6 to 10 years, no surgery because there is high risk of avascular necrosis. More than 10 years, the treatment is total hip replacement. Total hip replacement. Previous year test paper, previous year questions. Okay, I'll do that. I'll do that. I'll keep on telling you that which are previous year questions. Now, buddies, please tell me, it's 11 o'clock. It's been 3 hours. We have already been studying for 3 hours. Can I please take a small break of 10 minutes? Small break of 10 minutes. Everything is on. The link is on. The mic is on. The camera is on. Can we take a small break of around 10 minutes? So by my watch, it is, so we will be back. We will be back in sharp 10 minutes. We will be back in sharp 10 minutes. Raju ji, interlocking nail, it makes the tibia stable. It makes the tibia stable. That is why they have to use interlocking nails, because tibia happens to be a very, very huge bone. Strong bone it is. So we'll see each other in around 10 minutes. All right, dear doctors, let's start again, please. Why we took a small break for me to have a cup of tea or coffee. नहीं 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 भाई, आज ही पढ़ते हैं, बस अभी पढ़ लेंगे थोड़ा सा. Now, we'll continue reading the hip joint. Now here, remember this is the one which we studied. So slipped capital femoral epiphysis. That is the most common hip disorder in the adolescent. Now that can be asked as a one-liner question. Now, this disorder commonly occurs around puberty, especially in the overweight and obese children. But the most common cause is idiopathic. Right? Idiopathic. The clinical features not important. Yes, this clinical feature is important for Neet PG. The Drummond sign. Now, what is Drummond sign? Now, you ask the patient to do the flexion. आपने क्या कहा? You just ask the patient to perform flexion. And what do you notice? Upon doing flexion, there will be flexion plus external rotation. There will be flexion plus external rotation, right? That's important question for Neet PG. Okay. X-ray will show you Trathovan sign. Now, what is Trathovan sign? Now, see, if everything is normal, when you draw a line on the neck of femur and then you extend this line on both sides, what happens is this line passes through the head of femur. But if there is slip of epiphysis, what will happen? That the line which you draw on the neck of femur, it will not pass through the head of femur. Right? Now see here. This is normal. And here your patient is suffering from slipped capital femoral epiphysis. I hope I'm audible and the mic is working. Dr. Mahesh Ji, Dr. ABCD, Dr. Muhammad Talib Ji, I hope the mic is working. I'm audible. Let me see if I'm audible or not. ABCD, Dr. Muhammad Talib. Okay. It's working. Thank you. Okay. Now this is called as Trathovan sign. Now you see in the first image, everything is normal and this line is passing through the head of femur. Whereas if there is slipped capital femoral epiphysis, this line will not pass through the head of femur. Right? Okay, see here. Again, extremely typical. You draw a line on the neck of femur and this line will pass through the head. But here, if you draw a line on the neck of femur, this line will not pass through the head of femur. This is Trathovan sign. Treatment is close reduction and pinning. What has happened? This is normal. There has occurred slip. So you will do it like this. And then you will bring it back in the original position. And after that, you will insert a pin. Close reduction and pinning. That is the treatment. Okay. This was slipped capital femoral epiphysis. Now we move to the Next disease, Perthes disease. Now it is also called as leg, calf, Perthes disease. So that is the name of these three doctors who worked on this disease. The other name of this disease is coxa plana. Coxa plana. This name is not important. Now, what it is? Idiopathic, spontaneous. Spontaneous means without any trauma, without any trauma. Spontaneous avascular necrosis of hip. What is the most common cause? Idiopathic. What is the most common association? Protein C and protein S deficiency. Because of this deficiency, there will be increased clotting in the blood. Increased clotting in the blood. Now, what happens is between 6 to 10 years of age, body will develop a separate vein for the head of femur, separate artery for the head of femur. Now, what will happen? Because of this disease, a blood clot will form in the vein. There will be a blood clot in the vein. Now, what happens is that the blood which once enters the head, it cannot leave. The blood cannot leave because there is a big blood clot in the vein. So consequently, what will happen? This head of femur, it will become full of blood. But after a few minutes only, this blood will become deoxygenated. Fresh blood cannot enter. Fresh blood cannot enter because this head of femur is damn full of blood now. Because fresh blood cannot enter, there will occur avascular necrosis. Now, you see, the fresh blood cannot enter, so there will occur avascular necrosis. Why the fresh blood cannot enter? Because thrombus has formed in the vein. Outflow channel of the blood is blocked. That means blood which enters the femur head cannot escape. Cannot escape. So what will happen? Femur head will become full of blood, right? It cannot be replaced. Now, clinical features not important. Yes, on X-ray, we get to see crescent sign. Crescent means half moon sign, dead bone. Then we'll set to see gauge sign. What is gauge sign? So gauge sign is V-shaped defect. V-shaped defect on the lateral side of femur. On the lateral side of femur. Then we get to see bite sign. Femur head will be totally destroyed. That is bite sign. Investigation of choice is MRI. Treatment. No treatment is required in most cases. If any treatment is required, that is fenestration. Fenestration means creating multiple holes. Creating multiple holes that will decrease the pressure. Creating multiple holes so that the blood can come out. Fine, creating multiple holes, fenestration. Now, these two names are important for Neet PG if they want to ask you a difficult question, Catterall criteria and Waldenstrom criteria, there also you just have to remember the names, not the details, right? Okay. Hip joint dislocation. Again, we'll keep the things very, very simple. Hip joint dislocation, first of all, is not very common. Why? Because hip joint is the stable joint. Second, pure dislocations are rare. Usually they are associated with a fracture. You see, dislocation is very common in shoulder joint. The bones in the shoulder joint, humerus, and glenoid. Imagine their boyfriend, girlfriend can break up anytime. But bones in the hip joint, femur and acetabulum, imagine they are husband and wife. They cannot separate. If anything can separate them, that is divorce. Fine. So divorce naturally is a painful process. So if there is hip joint dislocation, there will be fracture included, right? Now, most common direction of dislocation is posterior. Remember, most common direction in shoulder dislocation is anterior. Okay. Oh, it's already written. Right. Now, posterior dislocation. Posterior dislocation is common in car injuries. What is car injury here? Dashboard hitting the knee. Dashboard hitting the knees. Especially in unrestrained passenger. Unrestrained passenger means someone who is not wearing a seat belt. Now here, the dashboard will hit the femur of your patient and femur will be pushed back. Now femur, it will hit the sciatic nerve. Fine. Sciatic nerve will be injured. Right? Now, when you look at the clinical feature will be FADIR. Flexion. You can see flexion. Adduction. Both the limbs are together. And then you can see internal rotation. FADIR. Flexion, adduction, internal rotation. Right? Vascular sign of Narath. Inability to palpate the femoral artery. Treatment is closed reduction. What is the meaning of closed reduction? The word closed means without giving skin incision. What is the reduction? Reduction means to bring the bones in joint together, to bring the bone and joints together, right? Complications. Two complications, sciatic nerve injury and avascular necrosis of hip. Okay. Anterior dislocation, it is common in bike accident. Now let's say, what are these? These are the petrol tanks of the motorcycle of your patients. Both will become your patient, A and B. If they don't have leg guard on their motorcycle, so what will happen? left leg of your patient A will hit the left leg of your patient B, like this, right? And your patient will suffer anterior dislocation, So it is said that it is common in bike injuries. Clinical features will be fiber, flexion, abduction, external rotation. So if you see over here, flexion, fine. And if you see, there is abduction, and then there will be external rotation. Now, femur head, when it is coming out, it will hit the three structures. What three structures? Femoral artery, vein, and nerve. All can be injured. Treatment is closed reduction. Now, central dislocation. It is common in the patients who have got weak bones, that is osteomalacia. Now, what will happen? There will be fracture of acetabulum. Femur head will enter inside. And if you insert your finger in the anus of the patient, you will be able to feel femur head on both sides. Fine. So digital rectal examination. On digital rectal examination, femur head can be palpated on both sides. Right? Treatment is acetabular reconstruction. Last topic in the hip joint, then we'll start with infections. Now, we have to read two fractures, intracapsular fracture and extracapsular fracture. Now, see, what are intracapsular and what are extracapsular fractures? See here. Let me erase, then I'll write quickly. Don't worry. Now, see, buddies. Here, this is the joint capsule. Right? Now, that means this much part of the femur is intracapsular. This much part of the femur is intracapsular. If a fracture occurs here, that will be called as intracapsular fracture. Now, if a fracture occurs anywhere else, that will be called as extracapsular fracture. But fracture generally occurs between greater trochanter and lesser trochanter. So GT, greater trochanter, LT, lesser trochanter. So fracture occurs here. This fracture is called extracapsular fracture, also called as intertrochanteric fracture. Right? See here. So if the fracture occurs between greater trochanter and lesser trochanter, it is called as intertrochanteric fracture. Look at this image. Fracture between greater trochanter and lesser trochanter here. Intertrochanteric fracture, right? Now, extracapsular fracture, most common age is 70 to 80 years. It occurs with trivial trauma, minimal trauma. Your patient will slip in the bathroom, fracture. Fine. Now, treatment, if the fracture is stable, dynamic hip screw. What is important? Image. If it is unstable, intramedullary nail. Now see, This image is important. This image is showing you dynamic hip screw. Dynamic hip screw, right? Or intramedullary nail. The nail will go inside the medullary cavity, go inside the medullary cavity. Now, the fracture is occurring at metaphysis. Any fracture which occurs at metaphysis, it heals promptly. It heals promptly. For example, supracondylar fracture of humerus. For example, Colles fracture. Colles fracture. Now, because the fracture is healing very, very early, malunion is common. See, here also malunion is common. Gun stock deformity, dinner fork deformity. So malunion is very common in the fractures which occurs at metaphysis, right? So here also the malunion is common. Okay, now we move to the next thing there, neck of femur fracture, neck of femur fracture. That is intracapsular fracture. Most common age is 50 to 60 years. Remember, for extracapsular, it is 70 to 80 years. Okay. Now here, as I told you, that fracture will occur here inside the capsule. Inside the capsule, anatomy is different. First, there is no cellular periosteum. Now, why cellular periosteum is important? Remember, periosteum, it helps in healing. It helps in healing of fracture. There is poor vascularity. Third, there is very small proximal fragment. Fine. Because the fragment is very small, so the alignment is very difficult. Alignment of both fragment is very difficult. Here you need to remember the Garden classification. But only thing which you need to remember is the basis. It is based on the degree of displacement. That is the only thing which you need to remember, not these details, not these details. Okay. Garden classification. So you see here in the first, there is incomplete fracture. In the second, there is complete fracture. In the third, there is complete fracture and some displacement. And in the fourth, complete fracture, complete displacement. Don't remember the detail. Just remember this. Garden classification. Powell classification. It is based on the angle of horizontal line. It is based on the angle of horizontal line with fracture line. So more the angle, more is instability. More the angle, more is instability. Here also, you need to remember just the basis. Treatment is slightly tricky. Please understand here. So we will divide our patients into two age groups. One is old patient, elderly patient, more than 60 years of age. There are chances that they may have osteoarthritis. Here the treatment is total hip replacement. And if they have no osteoarthritis, treatment is hemiarthroplasty. Hemi means half, artho means joint. Plasty means reconstruction. Half of the joint is new. Then the second group of the patients, they are comparatively young. Now, young patients, if they have a recent fracture, there are chances you may be able to give a satisfactory treatment. There are chances you may be able to heal this fracture. There you will do internal fixation. Internal fixation means you will give an incision and you will use screws, plate, or nails. Internal fixation. Now, if the fracture is 3 weeks old, that means it is an old fracture with which can have complication, But let's say there are no complications. So you just need to remember their names. And that is also important for Neet PG only. Now, if there are complications like avascular necrosis, the treatment is Mayer operation. We will wrap a live muscle. Yes, Dr. Feroz Ali ji, please. If I'm able to answer, why won't I? Just give me a minute. Dr. Suraj ji, yes, exactly. These are high yield topper. Dr. Lazy Medic ji, you asked about the infections. We are going to discuss infection quickly. Now, osteomyelitis. First question they ask is, how can the infections reach the bone? They reach the bone by blood. Next, other routes are there, but you don't need to remember. Now, what are the common bacteria involved? If the bacteria have reached the bone by blood, usually it is the single organism. But if they have come from other sources like skin infection, like open fracture, in that case, multiple bacteria are involved. They ask you what is the most common bacteria? Staph aureus. भाई ये एफएमटी का क्वेश्चन नहीं, ये तो ओबीजी का क्वेश्चन है फिरोज अली जी. I'll try to answer in the group. So, Staph aureus is the most common bacteria causing acute osteomyelitis. Bro, that's what I'm saying. It's an OBG question. So, OBG में हाथ थोड़ा तंग ही है भाई. Being a medical officer, you see FMT तो फिर थोड़ा बहुत देख लेते हैं, but OBG is an altogether different thing. Okay. So Staph aureus is the most common bacteria causing acute osteomyelitis, chronic osteomyelitis. I'll make sure your question is answered, Dr. Feroz Ali. It is the most common bacteria in developed countries, developing countries. Most common bacteria causing bone infection after surgery, after fracture. Most common bacteria in HIV positive patient. Now, in sickle cell disease, it is caused by salmonella if the infection is at diaphysis. Remember, if the infection is at metaphysis, then most common bacteria in sickle cell disease will be Staph aureus only, right? IV drug abusers. Bacteria responsible is Pseudomonas. Now for INECT or difficult question in Neet PG, they will ask you what is the most common bacteria causing osteomyelitis in IV drug users. And to your surprise, they will not mention Pseudomonas. If a rare thing like that occurs, remember Burkholderia also causes this infection, right? Okay, animal bite, Pasturella, human bite, Eikenella. If there are outbreaks, outbreaks means one after the other case. Today, one child, tomorrow, second, day after tomorrow, third child, fourth child, fifth child, outbreak. Fine. That means many children are suffering. In that case, the bacteria responsible will be Kingella, Kinge. Okay. Most common site is appendicular skeleton. Appendicular skeleton. Remember, appendicular skeleton is made up of 126 bones, including the clavicle. This is responsible for locomotion, the upper limb, the lower limb. Fine. They all are a part of appendicular skeleton. So limbs plus clavicle, limbs plus clavicle, right? Now, so a most common site is metaphysis of long bones. In adults, most common site is dorsolumbar spine. Bacteria around the world, most common bacteria is Staph aureus. But in India, bacteria causing infection is Mycobacterium tuberculosis. Now, most common age is 0 to 5 years. Why? Metaphysis is most common site of infection. First, it is a very vascular area. Even if there is a small injury, there will be a huge blood clot. Second, there is hairpin arrangement. Hairpin arrangement of blood vessel like this. Hairpin arrangement of blood vessels. So there will be stasis. Third, there is very low WBC count in this area. Very less number of white blood cells. Now, investigation, ESR and CRP. They ask you this question, CRP is better because the response is quick. There is infection, next day CRP will be high. ESR will be high after 5 days. Infection controlled. Within 2-3 days, CRP will fall. ESR will fall after 3 weeks. So CRP is better. CRP is better. What is the investigation of choice? Quick diagnosis because it will show you marrow edema. It will show you marrow edema. Second investigation of choice is bone scan. It shows increased activity of stem cells. X-ray, first sign is soft tissue plane, loss of soft tissue planes. That is seen between 1 to 3 days. That is seen between 1 to 3 days. Important. Periosteal reaction. What is periosteal reaction? That is new bone formation. New bone formation. Fine. That will be visible by 10 to 14 days. Now they ask you what are the benefits of bone scan. You see 2 cases. Your patient has single focus of infection. MRI will show edema. Bone scan will show activity of healing. Right? If there are multiple focus of infection, MRI will still show edema. Bone scan will show 2 focus of healing. So, bone scan can detect multiple focus of infection. Bones does not require sedation. Treatment is IV antibiotics for 1 to 2 weeks. Fine. Oral antibiotics for 4 weeks. They ask you, what is the gold standard investigation? Gold standard investigation is culture and sensitivity of the bacteria, right? Now, if antibiotics are given, they should be effective against Staph aureus. If they are given on empirical basis, that means based on the past experience, you should give those antibiotics which can kill the Staph aureus. See, there is no specific drug of choice, Dr. Khan. First is that antibiotics should be effective against Staph. That's one thing. Second thing, the antibiotic should have both oral and IV forms available. Now, those two antibiotics are Lizolid and quinolone. Quinolone, for example, ofloxacin, intravenous form also available, oral form also available, Lizolid, injection also available, tablet also available. That is the benefit. Okay. Right. Now, subacute osteoarthritis. Brody's abscess. So Brody's abscess basically is localized infection. The problem is Brody's abscess. What happens is that it appears very similar to osteoid osteoma. Yes, of course, Dr. Khan, in that case, we'll have to do surgery. It appears very, very similar to osteoid osteoma. So there will be pus here. Clinical feature, there will be pain. Right? The only difference between Brody and osteoid osteoma. See, for Brody and osteoid osteoma, age is same. Clinical features are same. The only difference between Brody and osteoid osteoma is Brody abscess is an infection, so it will occur at metaphysis, whereas osteoid osteoma will occur at diaphysis. That is the only difference, and this difference you should remember for Neet PG. Important, absolutely important. Okay, now another thing which occurs is subacute osteomyelitis, Gary's osteomyelitis. So what will be occurring here? There will be too much bone formation, excessive bone formation, like this. There will be excessive bone formation. Treatment again is the same, antibiotics. Now, osteomyelitis is associated with Sappho syndrome. And that is usually multifocal osteomyelitis, right? Septic arthritis is basically the infection of joint. The handwriting is not good here, please bear. Now they ask you, PYQs and all, what is the most common joint? Knee joint. The most common bacteria, where I'm writing questions that are actually PYQs only. Check it, right? If the joint prosthesis is present, then it is Staph epidermidis. The bacteria responsible is Staph epidermidis. In sexually active people, it is the gonococci. Gonococci. Clinical features are pain, fever, and pseudoparesis. Pseudoparesis means pseudo paralysis. Okay. Now, the risk is that your patient can develop bony ankylosis. That means both the bones can actually fuse with each other. We are worried about that, right? Septic arthritis, that is why is a surgical emergency. What is the treatment? Arthrotomy. Joint is cut, washed with antibiotics, right? Gonococcal arthritis is not a surgical emergency. Another thing which you need to remember is Tom Smith arthritis. That is septic arthritis of infancy. So they ask you, what is the most common age for Tom Smith arthritis? So it is infancy, 0 to 1 year. What is the most common joint involved? It is hip. So for Tom Smith, most common joint is hip. But for general, if they ask you what is the most common joint involved in septic arthritis, the answer would be knee. Answer would be knee. Chronic osteomyelitis. Any osteomyelitis more than 3 weeks. But you see what happens. First, there is initial infection. Bacteria will come inside the bone and they will release their toxin. They will release their toxins. Okay. Now, these toxins, they will cause blood clot. They will cause blood clot in the artery. Because there is blood clot in the artery, what will happen? The blood supply will be blocked. Because the blood supply is blocked, the bone dies. And the dead bone is called sequestrum. Fine. Now, bacteria, they eat away the dead bone. And the dead bone is converted into pus. Dead bone is converted into pus. The pus will ultimately leak out. The point from where the pus leaks out is called cloaca. Right? Now, sequestrum is considered the hallmark of chronic osteomyelitis. Is considered the hallmark of chronic osteomyelitis. Yes. Is the hallmark of chronic osteomyelitis. Hallmark means confirmatory sign. Treatment is sequesterectomy, removal of sequestrum. Now, what you do here is you don't close the wound. You keep the wound open. When you keep the wound open, that is called as external fixation. When you keep the wound open, that is called as external fixation. Now, when you are removing the dead bone, the bone, it starts to bleed. That red bleeding bone is called paprika. sign. It is called paprika sign, right? Okay. Tuberculosis. What you need to remember. See, the most common type of tuberculosis is pulmonary, and second most common is the one which affects lymph node. In the bones, the most common vertebrae affected are 11th thoracic, 12th thoracic, and first lumbar vertebra. Important. They ask you what is the most common pattern. Peridiscal means around the intervertebral disc. Second most pattern is central. Central means center of the vertebral body. Right? These are the two only important ones. This one is super important. Least common, posterior, spinous process, posterior. Okay. Right. Clinical feature. Most common clinical feature is gradual onset back pain. Twist, tenderness. Now, what happens is that tubercular pus can press the spinal cord. Tubercular pus can press the spinal cord. हाँ डॉक्टर साहब, वो आपको दिखाया था ना जो आई डिड डॉक्टर खान जी, कैन आई प्लीज आंसर यू इन हिंदी? आपको दो एक्सरे दिखाए थे जिसमें वो वर्टिब्रा क्रश हो गया बिल्कुल. दैट इज द कॉमन थिंग विच दे आस्क इन एग्जामिनेशन. नाउ your patient will develop early onset paraplegia. Paraplegia is a complication. Now, early onset paraplegia has got good prognosis. Just remove the pus and the symptoms will improve. Then we have late onset paraplegia. It occurs due to fracture of the spine. See, early onset paraplegia is due to pressure of pus on the spine. So that kind of paralysis will present early. Whereas the late onset is due to fracture. That will present very, very late. Fine. But the patient will not improve because the spine is broken. Your patient will develop kyphotic deformity. Kyphotic means bending forward, right? Then, how to stabilize the spine? By using TB. TB you will use in TB. So TB means you will be using talar brace. Talar brace. Earliest neurological sign is repetitive jerky movement. Repetitive jerky movement, right? Earliest X-ray sign is loss of curvature of spine, right? Spine will become straight. Pathognomic sign, that means confirmatory sign, is bird nest abscess. So bird nest abscess means a long abscess in the chest. Long abscess in the chest. Right? Treatment is ATT. Surgery is done if the bladder bowel control is lost, or if there is deformity, or if there is more than 50% sensory lost. 50% sensory loss. Right? Now, if there is any topic which you want to read, please tell me. Otherwise, I'll just do quick revision of the images and then we'll end the class. The important images only, I'll tell you that this image is important. Please watch this. ATT protocol, it is used for minimum 2 years these days. Fine, same HRZES, right? Minimum for 6 months, we'll use the full regime. And then for the next 12 months, we use 3-drug regime. Now, Austin Moore pin, not important, skip. Null spin, not important, skip. Yes, K wire, that is important. K wire is Kirshner wire, important. Kirshner wire. Now you see, Kirshner wire will be blunt at one end and it will be very, very sharp at the other end. Very, very sharp at the other end. Fine. K wire. Kirshner wire. Steinman pin. Steinman pin, absolutely same. Fine. The only thing is it will not be curved at the other end. Steinman pin. Denham pin, not important. Crutchfield tong, not important. Crush nail, again, not. Yes. Austin Moore prosthesis. This is important. This is used for hemi arthroplasty. So it will have 2 holes and single body. Single body means for the femur head and femur neck, there is just one body. Okay. Austin Moore. You see here, this one is Austin Moore and this one is Thompson. Thompson is single solid. The word solid means there are no holes. No holes. Single, solid. Bipolar. Bi means 2. So head is different, neck is different. Then you attach both of them together. Not important, not important. Yes, no, this is also not important. Buck traction. Yes, it is. Buck traction. So if you see weight attached to the side of bed, that is called as buck traction. Buck traction. You see there is a pulley. Bandage is wrapped on the skin of patient and there is a weight attached. That is why it is called as skin traction. In Russell traction, you see it will be tied on the roof. It will be tied on the roof and there will be a pulley. There will be a weight and knee joint will be in flexion. Russell traction. Bryant traction. So if there is flexion, if there is weight, fine, like this, it is not attached to the roof. That is Bryant traction. Bryant traction. Gallo traction. So you see if the hips of the baby are not touching the bed, if the hips of the baby are not touching the bed, it is gallows traction. It is gallows traction. Gallows traction. Remember it by the name gallows traction. Gallows traction. You see here, hips of the baby are not touching the bed. Dunlop traction is not used these days. 4-post collar not used. Halo traction, they can ask you this. Just remember this picture. Halo traction. Halo traction. Now, you see here, this device, one end is attached at the head, second end is attached at the pelvis. So this is halo pelvic traction. Halo pelvic traction. This is Bowler Brown splint. 1 pulley, 2 pulley, 3 pulley, right? Bowler, brown splint. Kramer wire, important. Kramer wire. It is used for temporary stabilization of fracture. Somi brace. It will be, touching the chin. Somi brace. Taylor brace is used for tuberculosis spine. Figure of 8 brace is used for bilateral fracture of clavicle. Aeroplane splint is used for brachial plexus injury. Cock-up splint is used for radial nerve injury. Important. Thumb spica is used for scaphoid fracture, is used for gamekeeper thumb, decurvane, tenosynovitis. But you just need to identify the image. Thumb spica. Stacks splint, stack splint. So this is how the stack splint looks like. Stack splint, you can also call it stacks splint. It is for mallet finger. Fine? Mallet finger. Stacks splint. Now, if it is bent like this, it will be called as frog splint. Frog splint. Not this, not this, not this. Von Rosen splint. It was used earlier, not now. This image, you must remember that this is a hip spica cast. Hip spica cast. Hip spica cast. Thomas splint. This is important. Q means PYQ. Thomas splint. Thomas splint. Dennis Brown splint. Super important. How will you identify Dennis Brown splint? There will be a crossbar. There will be a crossbar. Milwaukee brace, not important. Leon brace, not important. Okay, so this is hard cervical collar. Make sure you don't confuse it with Philadelphia collar. Philadelphia collar will have a hole over here, will have a hole for tracheostomy. Philadelphia collar. Let me see what other images are important. Right. So these were the only important images as of now about the splints. X-ray images I've already shown you. Let me please check if we have left anything, if you have left any question there. Yes, please tell me, what is this patient suffering from? Only 2 more minutes. Whatever questions are left, we'll do that. Now see, if you want to tell, it's okay. If you are tired, I'll tell. So you see, this is radial side. This is ulnar side. So there is UCL injury, ulnar collateral ligament injury. Fine. Ulnar collateral ligament injury, which is called as skier thumb if it is acute, which is called as gamekeeper thumb if it is chronic. Okay. So it is acute ulnar collateral ligament injury. Not the right one. Okay. A young motor mechanic slipped on the oily floor and landed on his left hand. He felt some wrist pain. Pain is aggravated when the man tries to grip object. Young man falling on the oily floor. Fine. Always consider scaphoid fracture, especially if he is not able to, grip the object. Dr. Khan, see, this is radial side. If this side is radial, opposite side is ulnar. This side radial because it is close to the radius bone. Opposite side would be ulnar, right? So injury occurs here, that is injury to ulnar collateral ligament. Okay. Now this is a typical image for square patella, squaring of patella. Squaring of patella. Jones fracture. Jones fracture is the fifth metatarsal base fracture. Fifth metatarsal base fracture. Jones fracture. Mechanism will be different. Acute injury. For example, we are playing cricket. Let's say me and Dr. Khan Saab, we are playing cricket. Khan Saab gave a huge hit. I tried to catch the ball. Ball should have landed here. But rather than landing here, ball landed on my thumb and it got stretched like this. You will be able to see that only from the history, acute and chronic. Now, the test being performed is Ganselan test for ankylosing spondylitis. Ganselan test. Right. So we have been able to discuss at least 175 questions here. Right. So any further queries here, please let me know. Any further query, please let me know. Now, this PDF which I will share, it has got comparison charts. All the comparison between benign tumors like this, right? So everything is written in a single page. Fine. Now here, this is about all the different arthritis. Everything is written in a single page about all the arthritis. So please do read this for quick revision. Then it has got all the one-liners written here. All the named surgeries, right? All the most commons in trauma. All the tumors. X-ray views. The X-ray views topic is important for Neet PG. Please, right? Okay. Now, the different classification names, that is also important for Neet PG, right? Splint, it has got name of all the splint, and I have shown you almost all these splints. Okay. So we're about to end in a minute or so. All the names of the cast, the test. So that is just for quick revision. All the named fractures. So this, you see, all the developmental disorders, they're given in a single sheet. So please do read this. All the upper limb fractures, they're given in one single sheet. I'll share this PDF separately also. Please do share, please do read this, right? Any query there, please do ask me, or you guys are too tired? Dr. Saab, I'll share it. I will share it by tomorrow, right? Because it's too late now and I'm expecting some guests. So probably they're already there, right? So I'll please allow me some time. I'll definitely share it tomorrow, right? Because it's a huge PDF. So I'll just put it on. The laptop will keep on converting it and I'll share it. As soon as I get time, I'll share it tonight only. Don't worry. So you'll get it in the Telegram channel. You'll get it in the Telegram channel. Okay. No further queries. You people are too tired. So many of you are sitting, but you're not having any of the queries. So I wish you all the best for your examination. Fine. Do super good. Yeah, FMG is also same thing, bhai. Same thing, same thing. There is no difference in the examination level of FMG and Neet PG. Yes, but it is for FMG also. देखो कोई फर्क नहीं है लेवल में. एग्जाम आपने देखा ही है जी खान साहब. FMG और नीट पीजी के एग्जाम में कितना फर्क रह गया कहीं. Right? So kindly allow me to end the class. We'll see each other pretty soon. Please do share the news of your selection. Right? Thank you. Thank you so much.